So good evening, everyone. On behalf of ISA East Zone and Fresenius Kabi India Private Limited, I would like to welcome all eminent and distinguished key opinion leaders across the zones and all the speakers today for the today evening webinar. I wish that this is going to be a great learning session for all of us. To start with, I would like to welcome our moderator for today evening, Dr. Manoj Kumar. Dr. Manoj Kumar is a governing council member of ISA National, and also he's an assistant professor of Department of Anesthesiology from Anugrah Narayan Magad Medical College and Hospital, Gaya. Also, he was ex-secretary Indian Society of Anesthesiology for Bihar and Jharkhand. So I welcome you all once again, and over to you, Dr. Manoj. Thank you.
I don't think Dr. Manoj is in this room right now.
Okay.
I think since Dr. Manoj is not, I think we must be having some technical issues. So I am Dr. Shaikat Sengupta. I am a consultant anesthesiologist and a member of Indian Society of Anesthesiologists of the East Zone. I'll be part of the program. It gives me great pleasure in welcoming you all. And thank you, Fresenius Kabi, to put it together. And I think a huge round of applause should be for Dr. Manoj to have organized this thing. It is my real pleasure and privilege to have two of my very good friends from the ISA National Headquarters. And it is always a pleasure. That moment, they are just a phone call away. And we have to just tell him that we are doing this kind of a meeting. And Dr. Naveen Malhotra, the Honorary Secretary of the ISA Headquarters, and the President of the ISA Headquarters, Dr. Muralidhar Joshi. If you ask me to tell their credentials, it will be very difficult for me because for the last 15-20 years, I have known them as Naveen and Murli. So I think for me, it still remains as Dr. Naveen and Dr. Murli. And since they're here, it is, I think, it's a great honor for the East Zone, Indian Society of Anesthesiologists to have them here. So I'll first ask Dr. Naveen Malhotra to just welcome us, the members from the East Zone. And I call him, he's like the bundle of energy. He's like the Virat Kohli of the Indian Society of Anesthesiologists. He is just pumped up always. I've never seen at any point of time Naveen lacking in energy and always full of ideas. Thank you, Naveen, for being here. And Dr. Naveen Malhotra, please put in a few words of encouragement and advice for all of us.
Thank you, Dr. Shaikat Sengupta, for such kind words. Yes, I confess. I breathe ISA, I smell ISA, I feel ISA. I am very happy about ISA East Zone doing this second back-to-back webinar today evening. A recent was held last month and it was also a runaway success. And I'm very happy that the academic activities under the banner of Indian Society of Anesthesiologists is going on very actively, very nicely in the East Zone, comprising of state of Bihar and Jharkhand, Odisha and West Bengal. And my dear friend Dr. Manoj Kumar, the ISA National Governing Council member, is taking all efforts to ensure that the academic activities are going on. Our worthy president, Dr. Muralidhar Joshi, is always keen that the show must go on. And that is being followed across the country. And on that pattern only, I'm very happy today that we have a webinar on obstetric anesthesia and critical care with eminent speakers like Dr. Saket, Dr. Nishan, Dr. Asif, Dr. Sandeep, Dr. Savata Tripathi, and we've got overseas from next year also, Dr. Das Gupta. So I know that all the members of not only of the East Zone, but across the country will have a good time listening to the academics. A very fruitful and useful session to all of you. Thank you very much. Long live ISA. Jai Hind.
Thank you, Naveen. Thank you very much for your lovely words as usual. But we are missing that background of ISA. That
Today's
what
slide
we
is
see when we are whenever seeing Naveen. So that's why I asked him. You're
very
back
soon.
home so
Very
early.
soon.
Okay, okay. Thank you. Thank you, Naveen. Thank you very much for your lovely words. And now I take this opportunity, since Manoj is not there, I'll do the MC work. I'm kind of got used to doing MC work. So it's good to have always a very dear friend of mine, very close, from whom I've learned a lot as well, Dr. Murlidhar Joshi, the president of ISA headquarters. And Murli, if you can just address this gathering, which is climbing up, which will soon be, I think, in 3-figure marks. And I think what has been nice is we have been always, like the previous one, Murli, I was talking to you, that we have got somebody from All India Institute Patna, somebody from Odisha, from the Bhubaneswar All India Institute. We have got Asif from Tata Main, Jamshedpur, representing Jharkhand. I am there from East Zone. You'll have to tolerate me for that. And we've got a good friend from Kolkata who's right now, as Naveen was saying, from the UK. Kind enough. Murli, please put in your kind words for us as well. Thank you.
I think Manoj has joined the cycle. I think Manoj wants to express something for it.
Before some words from Murlidhar Joshi, I introduce our chief guest. Dr. Murlidhar Joshi has more than 25 years experience in the anesthesia and pain management. He received Academic Excellence Award for the year of 2010 by the ISA national body in 2005. He presented a new technique of percutaneous epidural adhesolysis by the Selinger technique in the failed back surgery syndrome at 20th Annual National Conference of the Indian Society of Study of Pain at Pune, and performed the first epiduroscopy in the South India for the viewing the content of epidural space and facilitating adenolysis of the epidural adhesion. He is ex-treasurer of the Indian Society of ISA National in the year of 2011 and 2015. Currently, he is the president of the Indian Society of Anesthesiologists National, and he introduced the first Android application in the world of international pain management. I welcome our chief guest, Dr. Murlidhar Joshi. Sir, please.
Yeah, thanks for those nice words, Manoj. Of course, I don't know what else to say. Of course, my younger brother Naveen also is joining here, so it's more of a it's nice to see all of you. Let me put it that way. This COVID era, meeting people is so tough and all. Though Hyderabad started much earlier compared to the rest of the country, Kerala and Hyderabad, started early with COVID and all. We now our hospital is literally doing only predominantly non-COVID work. There's no COVID work at all. The reason being, it's good. It's good. I mean, the pandemic is moving on. It's like a monsoon. And in fact, right now we have torrential rain. It's raining cats and dogs, retreating monsoon. The last monsoon thing, which is supposed to leave from Gujarat and Rajasthan and all, it has crossed Madhya Pradesh. It is hitting Hyderabad badly. We are welcome. Water is always welcome. No problem issues and all. It's raining heavily. Those few words again. I'll re-endorse my statement. What I did in the last Bihar Jharkhand meet, what you had virtual conference. Yes, let's not forget 1947. That was the time West Bengal, Bihar, you put Jharkhand also. What you put, I put Bihar, are the most learned, educated, resourceful two states of India. Were only these two, Bihar and West Bengal. I reiterate that one. But having said that, because you are the big brothers of the East, a lot of responsibility comes with that one. So with that kind of responsibility, the Governing Council and ISA, editorial board, they have selected Dr. Saikat Sengupta. Saikat, sorry we had to trouble you. There was no other option for us. We could not trouble anybody else. We can't trouble Manoj because the Governing Council, he has to admit his job. So we had to punish somebody. So Saikat, sorry, we are punishing you for this one. But the question here is, let me put it the whole message. I can put routine this thing, president, secretary, good morning, good evening, wishes and all, but target oriented I'm coming here. Yes, the East Zone Journal, what was being requested by the East Zone and the Northeast Zone is on. It is officially communicated. And second thing is, most important thing is, we want you to work how we are going to do it, be in touch with ISA National Editorial. And the reason being, because already we have figured out who could be assisting the editorial team of the East Zone Journal, Northeast Zone. But make it East, Northeast, that will be happy, because we don't want to segregate. Because all the 7 sister states of India are a unique part of India. I don't know how many people, these people, when we talk about nuclear family, I don't know how many people have 7 sisters. So you should be proud, Saikat, you have 7 sisters. Man, see, daughter is an asset, son is a liability. So you should understand that one. So daughters are assets. So not this. I don't know how you are going to do it, Saikat. I don't know. We trust you. We are banking on you. We put that onus on you. And each state we identified as many people who might assist you. But there are a lot of young speakers. Each session we attend, we're realizing yes, there are a lot of young speakers and a lot of good things. Good people are there, and youngsters. You have to bring it out, the pearls and all those things, the wisdom. That lies on you, Saikat. Moving on to the today's event and all the great speakers and all those what you do, phenomenal. Saikat and Manoj, no problem. This is our India. हम ऐसे रहते हैं, हम हमेशा आवाज करते हैं. हमारी जिंदगी ऐसे है, हम हमेशा आवाज करते रहते हैं. चलता है, कोई बात नहीं. But very good speakers, very good content, lot of good content. Would like to see if it's possible, Manoj, the GC member from ISA, if we can have some meeting of this sort every month, that if it's possible. It's all request from our side, and ISA National is always willing to help you the way we can do it and all. It makes, because the bonding will be much more stronger. That's what our feel, and all the eastern states and all northern states, hats off from our side, the amount of resilience what you keep showing and keep doing the work and all those things. Maybe we are going back to the 1947 period, no problem. That East is strong. Always look East and go it that way. All the best for the event. All the best for everyone. And we look to receiving you, all of you, on World's October 16th World Anesthesia Day. All of you. It will collectively show the world. Across the world, it will say the India show towards the world. India show towards the world with all our Indian states and city branches and all those things. That's good phenomenon that has never happened in the world, and it's going to happen now. So all the best once again. Long live ISA. Jai Hind. Thank you.
Thank you very much, sir, for encouraging words for us. Thank you all the governing council body, especially President and Secretary, for choosing such a dynamic editor for Eastern and Northeastern Journal of Anesthesiology.
Manoj, I could not introduce Naveen. Please introduce Dr. Naveen.
Fine. Saket, please carry on.
Hi, होना चाहिए.
Please carry on with the academics. Please carry on with the academics.
So I invite our guest of honor, Dr. Naveen Malhotra. He is MD, DNB, FI PM, FICA, and FIA PM. He is the professor anesthesiology in charge pain management center at PGIMS Rohtak, Haryana, India. His area of interest is chronic pain management. He received ISA Bhopal Award for Academic Excellence in 2015. He received KPR's Young Anesthesiologist National Award in 2019. Publication is more than 162 and presentation is 310. And he is dynamic secretary of the Indian Society of Anesthesia under the HIJ guideline and president guideline with GC member. So we, Indian Society of Anesthesiologists, do lots of work, especially for the anesthesiologist, especially for COVID patient, and we are very thankful for our ISA national body for doing great job for patient as well as our anesthesiologists.
Second, one word. There's one program which is going on Bihar state. I just wanted to alert Manoj about that one. It's through WFSA. So that is something about the charity service, WFSA and the local district hospital. So I will alert you. I will alert you about that one, like Manoj and you, all of you on the board. The question, all the activities happening there, because activities happening there, and they're recruiting local people for helping rural and all those things. And ISA is also part of it, not completely different, but I'll alert you about that one. You can go about that one. I'll speak Naveen and we'll communicate appropriately. Okay. All the best. Go ahead. I think it's 6:20. It's time for us to leave. We'll join the regular group over there. Okay. We'll exit from here.
Thank you.
Once again, all the best, Saikat. All the best, Manoj.
Sir, please, Muralidhar Joshi, sir. Muralidhar Joshi, sir, please stay for a few minutes after deliberation speech by Naveen Malhotra, sir. So I request our...
Saikat, please start with the academics, please.
Okay.
Please.
Okay, thank you very much to all of you, especially President and Secretary, sir. And we will also arrange the next time webinar. So kindly give the blessing in future also. Thank you. Okay, our first speaker today webinar session is Dr. Saikat Sen Gupta. He is the senior consultant at Apollo Ganges Hospital, and he is the director of the research committee at Apollo Ganges Hospital, and he is Buddha of the ISA East Zone, and he is the coming editor in chief in ISA Eastern Zone Journal and Northeast Zone Journal. So I welcome Dr. Saikat Sen Gupta, sir, and he delivered Physiology of the Fluid in Pregnancy and Obstetrics. So I request Saikat, sir, to kindly proceed.
Okay, thank you. I think I am audible and it's also visible. So it's a pleasure and privilege to be with you all for the session on obstetric anesthesia and critical care. And at the outset, I would acknowledge the help that we have received from the headquarters of Indian Society of Anesthesiologists. Especially we've seen Dr. Manoj and Dr. Murli, ISA East Zone, the HCP forum to put this all together. And thank you, Sudeshna, thank you, Jayati, for having done it. It's courtesy all your hard work that it is possible. And of course, I have to thank Cns Kabi for putting it together as well. So the agenda for today, we will talk about the unique state in the fluid dynamics, the dramatic alterations, the maternal adaptations in pregnancy, the intravascular volume derangements, and we will talk about just, I think, the induction of labor, what happens, maybe cesarean section, which will be there. And the complicated obstetrics, since it will be taken up by my following speakers, I will try and skip that, if that is all right with all of you. So let us focus on the maternal adaptations, the cardiovascular and hemodynamics, which has a bearing in the fluid management during normal obstetrics or even in complicated obstetrics. The cardiovascular hemodynamics will just take through the timeline of changes, the changes in the blood volume, the systemic hemodynamics. We will focus a little bit on the changes related to labor and delivery, and when it gets resolution in the postpartum period. If you look to the timeline of changes, this cartoon kind of depicts it all. How when the changes happen, during which week of pregnancy, when does this plateau off, and when does it try to come down, the cardiac output, the mean blood pressure, and the systemic vascular resistance. You see, the maternal, and I've purposefully taken this as the first thing. The maternal systemic vasodilatation begins at approximately 5 weeks of gestation. It begins around that time. And the SVR drops by approximately 35 to 40%. So there's a huge drop in the SVR, the resistance. It kind of plateaus off in the middle of the second trimester. and it stays there. Now, I think I've purposefully taken, and I feel this is fundamental to the maternal adaptations, the cardiovascular maternal adaptations in pregnancy, the decline in this systemic vascular resistance. It is because of this creation of the high flow, low resistance circuit in the uteroplacental circulation and a vasodilatation, which possibly is because of the decreased vascular responsiveness to the pressure effects of angiotensin II and norepinephrine. So that's the physiology that is happening. There are additional mechanisms for this fall, which is possibly due to increased endothelian prostacyclin, enhanced nitric oxide production, and reduced aortic stiffness, which is mechanical along with it. So that was about SVR. The cardiac output peaks in the third trimester, and we'll keep coming back to this. And this third trimester peak is related to the peak in the heart rate, which happens in the third trimester as well. The blood pressure, though it changes, but it comes back to pre-pregnant levels during the third trimester. It should, unless there is a pathophysiology. From there, let us shift to the total blood volume, the plasma volume, and the red cell volume in normal pregnancy. The expansion of the plasma volume and the increase in the red cell mass, it begins around this fourth week. There's this two big spots that we have. The fourth week of pregnancy. It peaks around this 28 to 34 weeks and then plateaus till saturation. This expansion leads to expansion of blood volume from the 65 to 70 ml per kg in the non-pregnant women to 100 ml per kg in the pregnant women. The plasma volume increases by 10 to 15% from the 6 to 12 weeks of gestation, rapidly increases up to 30 to 34 weeks. We kept talking about blood volume. It's mainly due to this plasma volume. Plateaus post 34 weeks. Till we have got nearly a liter to a liter and a half of in gain, and we have then a total plasma volume of 4,700 to 5,200 ml, which is nearly 30 to 50% above the non-pregnant levels. It plays a part. It is metabolic, demands of the uterus and the placenta, facilitating delivery of nutrients and removal of waste. Plus, this expansion also takes into account this, we will talk about this impaired venous return, which happens due to a very mechanical cause during supine and standing position, as well as this is a way of protecting this excessive blood loss that can happen during pregnancy. Now, what causes this rise in plasma volume? If you do assays of plasma renin, you'll find that the plasma renin is increased, while the atrial natriuretic peptide levels are slightly reduced, which makes us think, or physiologists think, that this underfilled vascular system is the primary response, wherein there is the systemic vasodilatation and vascular increase in vascular capacitance, and the plasma volume that is expanding is a result of this primary mechanism, which is underfilled vascular system. Because the plasma renin activity is not elevated, and or rather it is not low, neither is the ANP raised, which would have happened if it was the converse, that is, the expanded plasma volume is the primary thing. And the other thing is that if you keep on adding sodium to these pregnant women, it does not cause any further volume expansion. So the vascular changes precede the expansion of the plasma volume. I think this is for especially students who are attending this, and good to see that there are more than 100 already attendees over here. So the raised plasma volume is, as we discussed, more than a liter, and it's distributed among the fetus, amniotic fluid, extracellular and intracellular spaces. Is there any way we can improve if the physiology is deranged? Unfortunately, no. There is no specific measures that are available to increase the plasma volume. And if it happens physiologically low, even if you push in fluids, you will not be able to correct the pathophysiological changes that are happening. Maybe if you can increase dietary protein by increasing the colloid oncotic pressure, then you possibly can do something to the intravascular space and correct the dehydration if it is there. Now, coming to red blood cell mass, we talked about this, starts to increase around 8 to 10 weeks. And if they're supplemented with iron, it goes up to around 20 to 30%. This is mainly led by erythropoietin to meet the metabolic requirements of oxygen during pregnancy. And this increase in intravascular volume, which is more than the increase in the red cell mass, causes what is well known to us, the dilution or physiological anemia of pregnancy, physiologic anemia of pregnancy, mostly around the 30 to 34 weeks of pregnancy. Assuming the normal renal function, the blood volume and the constituents return to non-pregnant values by 8 weeks postpartum, which is a result of diuresis, and the hemoglobin begins to increase from the 3rd postpartum day. There is a benefit from this physiologic hypervolemia and anemia because it decreases the blood viscosity, decreases resistance to flow, facilitates placental transfusion, and lowers the cardiac work of the mother. It's increased up to 1.5 liters, as we discussed earlier, accounts for this blood loss that can happen during vaginal delivery as well as during cesarean section. And this peripartum hemorrhage, also that you remember that during the involution around 500 ml, which is known to all of us, comes back to the maternal circulation when increases the cardiac output and takes accounts for this, even this loss that can happen in the peripartum period. Similar to the rise in plasma volume and similar to the decrease in systemic vascular resistance, the increase in cardiac output improves the distribution to the placenta, kidneys, and skins. And not only about nutrients and excretion, it is important for the maternal temperature control. And the increase in the organ flow, especially the renal organ flow, is possibly due to this ovarian hormone relaxin, which is controlled by HCG. If physiological anemia does not occur, is it harmful? Yes, it is. If you look at, this was published a couple of years back, the Swedish Medical Register, and if you found that the hemoglobin, if the concentration went above 14.6 during the first prenatal visit, there was an increased risk of stillbirths, the odds ratio of 1.8, a higher odds ratio for antepartum stillbirth without malformations, and a much even higher odds ratio for preterm and small for gestational age. So you need this physiological anemia, and this risk will persist even if the hemoglobin dips down, and because it is of this high viscosity, which causes this risk of thrombosis in the uteroplacental circulation. So if it doesn't happen, then it's not good. Systemic hemodynamics, we'll just talk about heart rate, which you have already discussed. It goes higher during the 3rd trimester. In the early pregnancy, the cardiac output is primarily related to the stroke volume. But in the later part, the cardiac output that increases is majorly contributed by the increased heart rate. So we have a 30 to 50% increase in cardiac output, and the contributing factors are here. If you can see, there is this thing in red, which is in supine. It changes in the lateral position as well. Elevation, we talked about this. And the cardiac function, the cardiac contractility is improved in pregnancy, and it is possibly due to an increased left ventricular mass, which increases by around 40 grams, which is 34% above the baseline in the early 3rd trimester. The ejection fraction remains normal because it's dealing with a high volume. The changes in blood volume typically should affect the right side of the heart, but the central venous pressure remains normal to the non-pregnant state. And this is because of the decrease or a substantial decrease in both the systemic vascular resistance as well as in the pulmonary vascular resistance. So the cardiac output, which starts to increase because of the stroke volume in the first weeks, then it kind of plateaus during the 2nd trimester. There is a dip in the 3rd trimester, but is still higher above until and unless the mechanical obstruction is causing this huge dip. But if they turn to the lateral position, the dip does not happen. And the increased vena cava compression, as we talked about, as well as the increased uteroplacental circulation causes this dip. But if they go to the lateral position, it is not seen. And this is what is explained in this slide, that after 20 weeks, assumption of the supine position decreases the cardiac output by 20 to 30%. The IVC being compressed by the gravid uterus, reduction in venous return to the heart being the primary thing. And this is known, as we all know, the postural hypotensive syndrome. Classically, you can figure out by the increased maternal heart rate and the wide pulse pressure. And it also causes non-reassuring changes in the fetal heart rate. And the only way of doing it is mechanical. The left lateral tilt is the only way that it can do it. And if you can add a wedge, then it improves it even further than just a left lateral tilt. Now, the changes in hemodynamics during labor and delivery, it is mainly due to anxiety, exertion, pain, and contractions, and the uterine involution. And you can see that it is of two types. The increase in cardiac output in blue is without the contractions, and in red is during the contractions of the uterus. The increase is 50% in early labor, it becomes 25% during the active phase of labor, and it becomes 50% during the pushing in the second stage of labor. This is the rise in the cardiac output. When during contraction, the blood from the uterine sinusoids is forced into the systemic circulation with each uterine contraction, there is a further increase in preload, and the cardiac output is increased further, which is shown by the red dotted line. If you give epidurals, the baseline increase in cardiac output is attenuated, but you will not be able to attenuate the rise in cardiac output and the blood pressure, which happens with uterine contractions. The position change from supine to lateral decubitus again increases the cardiac output, and here the cardiac output is, as we discussed, hugely dependent on the preload. Look at that hump that is happening later on, and this is immediately postpartum, and this is the cardiac output which goes up to 80% from the pre-pregnant stage, and this is because of the autotransfusion during the uterine involution. So it will take some time for it to go down. The systemic blood pressure and diastolic blood pressure goes up, and it depends upon uterine contraction, position of the patient, and amount of pain. And not only the blood pressure, the amniotic fluid pressure, the intrathoracic venous pressure, the CSF pressure, and the pressure in the extradural compartment also goes up, which is bearing for anesthetist. When you're talking about just fluid therapy in obstetrics, if you look at it, the reason you need to possibly give is if they are into a prolonged period of fasting, then you might have to use fluids. The most important, the vexing thing, and which is the only thing I will dwell some time, is about the fluid, what you need to do during a neuraxial block. And I think surgical site and complicated obstetrics will be taken up by my subsequent speakers. So in neuraxial block, you know that spinal anesthesia will create hypotension. And if you look through all literature, you'll find that the only way of treating this hypotension is with only three things, isn't it? It's IV fluids or mechanical left uterine displacement so that the compression goes away, and prophylactic vasopressors. So since we are talking about fluid, we'll stick to fluid. The problem that happens in obstetric population is assessment of fluid status. I think we will have to still rely on this not very confirmatory things like static parameters like heart rate, blood pressure, urine output, and keep on with them, or maybe even CVP for whatever value it has. Because the dynamic parameters like pulse contour analysis, if they're spontaneously breathing, goes out of the window. Even if you are mechanically ventilating these people, pregnant women, because of this gravid uterus and because of the gravid uterus, which was also influencing the intrathoracic volume, that the pulse contour analysis and the pulse pressure variation or the systolic pressure variation of the that you're looking into it may not be very, very accurate. There is this also that if you're trying to look at it, the IVC diameter will be very difficult to look at from mechanically nearly impossible. And there is also this issue that the TE in pregnant women can be also hugely challenging. People have kind of thought that this might help, which is this Infinity. I have no clue as to how it works, so I'll not be able to do. But many people have suggested that this may have some bearing in how to assess fluid status. Now, fluid during spinal anesthesia, this is the conundrum. Do you preload, do you co-load, or do you don't do anything? I think the Cochrane database in 2006 and this meta-analysis by Banerjee published in 2010 clearly stated that preloading is possibly of no value anymore. So preloading, which was advocated by Woolman and Marks way back in 1968, which said that give 10 to 20 ml per kg of IV crystalloids 15 to 20 minutes prior to a subarachnoid block. But we now realize that it can release a huge amount of ANP, which can damage the endothelial glycocalyx, which is hugely about the fluid homeostasis. And even with colloids, it can damage the endothelial glycocalyx. Plus, you have the issues with anaphylaxis and derangement in coagulation. Co-loading may be a little safer than preloading, but still has this risk of decreasing oxygen carrying capacity, risk of pulmonary edema. And whether you preload, whether you co-load, the requirement of vasopressors has been the same, and vasopressors still becomes the cornerstone of management of hypotension during a subarachnoid block or in a central neuroaxis block. Is there any neonatal effect? If you see that an acute increase in maternal vascular volume does not promote fluid transfer into the fetus, whereas an acute decrease in the maternal colloid oncotic pressure by administration of hypotonic solutions can cause fluid shifts into the fetus. So a maternal oncotic pressure is possibly more responsible than the vascular hydrostatic pressures to change the neonatal fluid dynamics. Does the choice of fluid matter? Whether it is still colloid or crystalloid, there is no change in the way the maternal heart behaves, and neither crystalloid, as we discussed, nor colloid, nor preload, nor co-load could change the way that you need, and vasopressors are possibly the only way of changing or managing hypotension during a subarachnoid block. So what are my take-home messages? I think when you are thinking of giving fluids, whether in a non-complicated obstetric population or even in a complicated obstetric population, you will have to figure out there are certain things that are happening because of the maternal adaptations, and primarily it is with the systemic vascular resistance. Also affecting the cardiac output. Physiologic anemia is something that you have to factor in. And about fluid derangement, I think neither preload nor co-load, I think the answer, even if you are managing hypotension, is co-load. Just I would conclude saying that I think I just left it out deliberately. If during normal vaginal delivery, if it's an induced vaginal delivery, is there any help in using fluids? I think if you look again at the Cochrane database, it says that giving IV fluids over and above the oral intake, if the person can take, does not change any outcome. Whether you give a normal saline or you give balanced salt solution, or if you give colloids. So the take-home message is, I think, just be where you are and keep the physiological changes in mind. Thank you very much. For a pleasure, patient sharing.
Thank you very much, Dr. Sekat. Dr. Sekat Sengupta, sir, for nice presentation. You already presented very nicely. You are Buddha of East. Thank you very much for. We can ask question to after completion of two speakers. Then we can ask. From the audience side as well from moderator. Thank you. I request Dr. Sandeep Dr. Sandeep Bhavkar, who is currently working as a manager, medical affairs and clinical research, India and South Asia at the Francis Kabi. Previous appointment as a medical advisor about India Limited and as a medical advisor at Brigham India Private Limited and assistant professor at Department of Pharmacology, Government Medical College, Aurangabad. His education qualification is MBBS from the BJ Medical College and General Hospital, Pune, and MD Pharmacology from the Government Medical College, Aurangabad. So publication in the national and international journal and the conference presentation on various therapy areas. So I request Dr. Sandeep Bhavkar to kindly pursue. Your topic is fluid therapy, worldwide update.
Thank you so much.
Obstetric surgery.
Right. Thank you so much, Dr. Manoj. Am I audible?
Yeah.
Okay, then I shall begin the presentation. Yeah, right. Thank you so much. So first of all, I take this opportunity on behalf of Cns Kabi to thank ISA East Zone chapter. I'm very grateful for this opportunity and to include my talk amongst various eminent speakers on different topics. So I will just begin the talk. So in the previous session by this brilliant presentation by Dr. Saikat sir, he has already taken us through various aspects of fluid dynamics during the normal stages of pregnancy, and also what are the, he has just touched upon the IV fluid therapy during the obstetric surgery and different procedures. So in my talk, I'm going to talk about colloid updates and what is the role of colloids in obstetric surgery. So I will just take some points from his talk as well. So I will just begin the talk by enumerating why do we require fluid resuscitation in patients who require surgery. So there are various reasons. We have seen the fluid dynamics in normal pregnancy, but when we talk about the surgery over say, it is not very physiological change. We are intervening. So it is an interventional procedure. So in those cases, fluid therapy is required to provide daily basal fluid requirement, especially when the patient is not able to take fluids or take diet orally. Then to maintain or achieve normovolemia and to maintain hemodynamic stability. Now we have seen different changes during different stages of pregnancy, and at the time of pregnancy or at the time of operative intervention, these changes even take place rapidly, and there could be hemodynamic instability. In that case, fluid requirement or fluid resuscitation is required. The restitution of fluid balance between different fluid compartments. Now, when we talk about the increase in fluid volume overall during pregnancy, we must be aware of the fluid compartments. That is, some fluid, whatever increase in plasma volume, it also includes increase in amniotic fluid, increasing fluid in intracellular compartments, in extracellular compartments, and in intravascular compartments. And during the surgical operation or during the surgical intervention, the fluid compartment that gets affected the most is intravascular compartment. That is one thing. Then maintain adequate plasma colloid osmotic pressure. This colloid osmotic pressure is related to intravascular compartment one more time. Then fluid resuscitation is required to enhance microvascular blood flow. So again, so far the intravascular compartment is intact and providing the circulation. It is contributing to the preload and cardiac output, and that cardiac output eventually is contributing to the microvascular blood flow. Then, and microvascular blood flow is related to the oxygen delivery to tissue cells and cellular metabolism. Also, fluid resuscitation is required to prevent the cascade system activation and trauma-induced increased blood coagulability. Now, the talk about the glycocalyx endothelium intactness, it is related to the fluid amount of fluid volume in the intravascular compartment and overall the normal fluid status in the patients. In addition to all this fluid resuscitation in all the surgical cases, in obstetric surgery, we have to be very cautious about the uteroplacental perfusion, and at that time, whatever the intervention during the surgery we are doing, we have to be very watchful about that perfusion not getting hampered during any kind of intervention. So what are the specific principles for acute blood loss? Here specifically for acute blood loss during the obstetric surgery. So initial reduction in total vascular content is usually well tolerated because of the compensatory increase in cardiac output. Primary treatment goal for the acute blood loss setting is to restore that intravascular volume compartment and also, of course, to stop the blood loss. And red blood cell transfusion may not be available all the time, and it should not be dependent upon to expand the vascular volume. Now, this is to classify the IV fluids. We know IV fluids are classified into crystalloids and colloids. Colloids are again classified into natural occurring colloids and artificial colloids. It could be proteinaceous or non-proteinaceous. So the difference, the very basic difference I'm going to highlight using this basic diagram. So here we are looking at the intravascular compartment, interstitial compartment, and intracellular compartments. Though we do not give that much importance to the fluid selection depending upon the compartments, the basic thing that we have to keep in mind, this is again dependent upon the physiological principle of the fluid transport across the cell membrane or cell membrane barrier. So electrolyte containing compounds, solution that is crystalloids, it may contain or may not contain glucose. So it is restricted or it spreads across from the intravascular compartment to interstitial and intracellular compartments, whereas colloids are restricted only to intravascular compartment. So the basic difference is when you have to target the colloid osmotic pressure, when you have to increase the cardiac output, and when you have to increase the preload in any operative setting, the fluid to be selected is colloids. Crystalloids are used when the patient is not able to take oral intake and for overall intravascular compartment replenishment. So the point that I want to highlight is amount of crystalloid infusion required to maintain normovolumia when compensating for blood loss of around 15 to 40% is equal to 5 times the volume of blood lost. For greater losses, amount of crystalloid required to maintain normovolumia increases exponentially. Now, why is the exponential increase in crystalloid volume requirement not beneficial? Because the complications of fluid overload start to accumulate very rapidly. And it is because the accumulation of fluid in interstitial space, which is not completely drained. So for massive use of crystalloid is not effective in restoring the normal microvascular perfusion because it is not adding to the preload and cardiac output. Second thing, it is getting accumulated in all the different compartments, leading to fluid overload, changes such as pleural effusion and all the peritoneal effusion, etc. if fluid compensation goes beyond the normal requirement. This is just to summarize the different phases of fluid therapy specifically required in cases of acute blood loss, and sometimes it is also related to the surgical fluid loss and what fluid therapy strategy should we adopt to. So Rose concept, rescue, optimization or stabilization, and de-escalation or evacuation. In the rescue phase, when there is phase of hypovolumia, colloid solution should be used, that is for the initial rescue phase. In the maintenance phase of optimization or stabilization, crystalloid solution can be used for the maintenance phase. But just remember, for increasing the initial preload requirement, colloid has to be used. Now, one of the colloid I'm going to talk about, focus on specifically is the starches, hydroxyethyl starch. So when we look at the evolution of starches since 1970s, these have evolved or looking at the improved safety, efficacy aspects. And finally, we have currently hydroxyethyl starch and also balanced hydroxyethyl starch 130 by 0.4. So these numbers are related to the molecular weight, degree of substitution, and substitution pattern, which improve the safety aspect of this solution. So why this new generation starch such as Voluven or balanced hydroxyethyl starch is provide improved safety is because improved of the chemistry improvement such as decreased molecular weight, decreased degree of substitution, and optimal molecular weight distribution. So these provide adequate volume effect, improved in renal elimination without any kind of accumulation in plasma and without any kind of tissue storage. So overall safety profile is improved. Now, Dr. Saikat sir also mentioned about the use of the fluid may be related to anaphylaxis, but when you talk about the colloid overall, the chances of allergic reaction or anaphylaxis, if you look at all the colloid groups, We can say that gelatins carry maximum chances of anaphylaxis reaction, followed by dextran, followed by albumin, and hydroxyethyl starch have relatively least chances of allergic or anaphylactic reaction. Now, safety of modern starches during the surgery overall, if you look at the systemic review, meta-analysis, different population, because it has gained a lot of attention over a period of years, the specific point that I want to highlight here is that data in the peer-reviewed literature do not suggest any kind of adverse safety signal when tetra starches, that is the modern third generation starches, are used intraoperatively or in the immediate post-operative period or both. I'm going to, so this is again the graph depicting that strong trend towards the reduced mortality in patient when used third generation hydroxyethyl starches as compared to the comparator, and reduced blood loss and reduced requirement of transfusion in patients treated with third generation modern tetra starches such as Voluven or Volulite. I'm going to now focus mostly upon the obstetric surgery, what relevant data we have about the use of Voluven as compared to Ringer's lactate preloading before spinal anesthesia for cesarean delivery. Now, this is a Caesar trial, which is randomized double-blind multicentric trial. And the basic purpose for this trial was to look at the efficacy of this crystalloid versus colloid in avoiding the spinal anesthesia-induced hypotension. Now, as we have seen, there is decrease in systemic vascular resistance, and because of spinal anesthesia, there is sympathetic blockade leading to venodilation. So all these changes require the use of vasopressor, but before vasopressor, we have to see if the fluid supplementation can deal with this hypotension issue. So in this trial, the patients were randomized, a double-blind trial, to receive either Voluven, that is 500 ml of hydroxyethyl starch, followed by 500 ml RL in one group, and second group received 1000 ml, that is 1 liter of RL alone. And the primary endpoint was incidence of hypotension following spinal anesthesia. Now, this is a Kaplan-Mann curve which showed that after the spinal anesthesia, what is the time duration for the occurrence of hypotension. So incidence of hypertension and at the same time severity of hypertension. Severity of hypertension is duration of hypertension and how much of vasopressors are required to deal with that hypotension. Now, from this graph, it is very much clear that preloading with hydroxyethyl starch, that is with colloid, as compared to with crystalloid alone, can delay the onset of spinal anesthesia. And also, we will look at another evidence also where the requirement of vasopressin was also decreased with colloids as compared to with crystalloids. So overall, the conclusion of Caesar trial was that mixed Voluven plus RL preload significantly improved the prevention of maternal hypotension as compared to crystalloid use alone, and maternal and neonatal adverse effect events assessed systematically did not show any kind of change in both the groups. This is another trial. This trial was conducted in Greece, where they looked at the effect of again colloid versus 1 liter of Ringer's lactate preload on hemodynamic status for patients undergoing spinal anesthesia for elective cesarean delivery using arterial pulse contour analysis. Now, this is a dynamic fluid parameter which Dr. Saikas mentioned about, which should be monitored. Again, in this patient population, one group received crystalloid alone, another group received colloid in addition to crystalloid, and they looked at the effect and overall assessment of spinal induced hypotensive episodes and requirement of vasopressor. Now, from this graph, the group receiving Ringer's lactate required the vasopressor more, and the hypotension episode were not statistically different in both the groups, but what was statistically different was the requirement of vasopressor when used with colloids or when used with crystalloid. Now, this is arterial pulse wave contour analysis. Here also, it was not statistically significant, but the number of patients having hypotension was less with patients receiving colloid preloading. Now, to conclude, this trial showed that preloading with 0.5 liter colloids, such as hydroxyethyl starch, produced more stable hemodynamic changes compared to 1 liter of crystalloid solution. So update on volume therapy of obstetric. Another review article also mentioned about the usage of vasopressor are required, no doubt, but when you use colloids, the requirement of this vasopressor go on decreasing, and more what we can say hemodynamic stability is achieved. I will just rush through some of the slides in the interest of time. That is, this is very recent May 2020 article about the use of colloids, overall kidney function, effect on kidney function in cardiac surgery cases. So they looked at the primary endpoint of kidney function as urinary concentration of NGAL, which is the early marker, predictive biomarker of acute kidney injury. And when you look at the comparison of hydroxyethyl starch third generation, that is Voluven against albumin, so during cardiac surgery, similar effects were observed in terms of postoperative kidney function, coagulation, platelet count, and platelet function overall as compared to other colloids. So the fear that the colloids can cause or hydroxyethyl starch can cause renal impairment is not valid at this point because of the improvement in the colloid structure and hydroxyethyl structure overall. So this is one of the Dr. Saikar sir also mentioned about the inflammatory changes and glycocalyx degradation because of the colloids. So to about those points, just some review articles about the effect of hydroxyethyl starch on the inflammation, neutrophil recruitment, and neutrophil extracellular trap formation. So from this graph, it is very much clear that the inflammatory changes, neutrophil recruitment, and trap formation are decreased with hydroxyethyl starch as compared with other electrolyte solution. And from this study, the data shows that administration of Voluven during systemic inflammation modulates inflammation by reducing number of platelet neutrophil aggregates and leukocyte recruitment into different organ structure. Now, finally, I will just mention about the glycocalyx. So basically, these are the coverings in the over the endothelium structures, and during the sepsis stage, this structure gets damaged and it leads to increase in vascular permeability. So that is the reason why during the sepsis stage or during the septic shock stage, because this layer has damage already, we avoid using colloid for sepsis cases. But in surgical cases, this glycocalyx layer is very much intact. And this very recent, that is 2018 article in the Critical Care Journal highlighted the role of hydroxyethyl starch. So basically the same third generation hydroxyethyl starch, that is Voluven. The article highlighted that this Voluven diminishes the glycocalyx degradation and decreases the vascular permeability during systemic and pulmonary inflammation. Now, though in septic shock it is not to be used, it is to be avoided, but the recent trial has shown that use of Voluven has improved upon this glycocalyx layer, the overall viability and the overall what we can say healthy status of this glycocalyx layer. And reports point to the possible interaction of colloids and glycocalyx. It is surprising that in septic animals also it is showing protective effect. So this is just to talk about this point that colloids are safer in surgical cases, in obstetric cases also. Though vasopressor are the agents we most are accustomed to use during the hypotension episode, we have to also remember that vasopressors such as ephedrine have chances of neonatal acidosis. Also, vasopressors such as phenylephrine can induce reflex bradycardia and they can compromise the uteroplacental perfusion. So vasopressors definitely are to be kept in mind and at all times in the surgical patient. But if the fluid resuscitation and fluid replenishment can do the work of reducing the requirement of vasopressor, we should definitely look into that aspect, and we should definitely look into aspect of safety of Voluven or safety of colloids during the surgical and overall outcome for maternal and neonatal outcome. So when to use for volume expansion in cases of hypovolemia and for optimization of cardiac performance, and where to use during the operative cases, during the trauma cases, wherever there is blood loss and wherever there is requirement to avoid and to treat the hypotension. So to summarize, I will just summarize very briefly that balanced hydroxyethyl starch, third generation hydroxyethyl starch derives from vaccine-based starch, is safe and efficacious compared to other colloids. Balanced hydroxyethyl starch gives the advantage of reducing the risk of hypochloremic acidosis, and there is no risk of renal failure with these third generation starches in perioperative settings and in trauma. And we have to look at the volume replacement, keeping in mind the physiology of fluids and which compartment fluid stick to and what is the outcome after giving this fluid. So with this, I hope that I'm very much in time, and thank you so much.
Dr. Sandeep Bhapkar, you have presented this topic very nicely, and some question for you both. My first question for Dr. Saikat Gupta sir. Is there any? You already read now?
Yeah, I can read it.
Hello.
Is there any minimum amount of IV fluids? This is from Dr. Diptima Majumdar. We should be administering to a mother undergoing cesarean section under spinal who is NPO for 6 hours. I think if you look at it, if you scan through literature, I don't know, we're getting a huge amount of found from somebody who needs to be muted. Sudeshna, can you look at it, please? Yeah, thank you. It's gone. So, if you scan literature and if you look at, don't go too long back, go back by say 2 decades, 20 years, you will find that the recommendations have changed hugely over this last 20 years. This marks things, and especially when we were residents, we were told that you have to preload. Then it came down that preloading is not doing any good because you're still using that amount of vasopressors. Then you said that you at least co-load. I think you do not have any recommendations to tell you how much fluid that you need to use. I think there are few gut things, because the problem again with obstetrics is, and cesarean section is, fluid volume estimation, because the volume status, because you will have to rely on the static parameters. The dynamic parameters, as I understand, even though the Greek trial that Sandeep was talking about, the pulse contour, I have huge reservations on this, because the fundamental physiology of pulse contour assumes that it is mechanically ventilated, uniform tidal volume, not a low tidal volume, and also that there is nothing that is happening to the intragastric compartment. So, to cut it short, you will not be able to understand these changes. So, to me, the way I look at it today is that if I'm okay with the pain, if I'm okay that my blocks are working, and if I still, I won't wait for the mean arterial pressure to fall, I would run phenylephrine infusion. I have come out of the intermittent boluses, and I would run a phenylephrine infusion and to keep the mean arterial pressures normal. So I know that the physiology change that is going to happen because of the central neuroaxis block is a fall in SVR. So I will not wait for the blood pressure to fall because of this fall in SVR. So I would give phenylephrine. And in fact, if you look at publications which are coming out, they are saying that you can even use, if you're worried about the reflex bradycardia with phenylephrine, use noradrenaline infusion. We had used ephedrine once upon a time. Today, we possibly avoid ephedrine for the same reason. And I think Dr. Ravi Wankhede, he says that how do we select fluid therapy, both preloading? I think, Ravi, just like you, I also don't have any answer to that. We'll have to stick to gut feeling. So you run a fluid. I would run a balanced salt solution once the IV line is on. And after I have given the spinal, once the position is done, I would run phenylephrine. And I think Dr. Arpita wanted to know about the fluid load that is optimum and any specific treatment for the nausea, vomiting. No, I think whatever you are saying is absolutely correct. I won't say anything beyond that at all. The colloid versus crystalloid dilemma. I think again, this is a Fresenius sponsored event, but pardon me, Fresenius, for saying this. You see, the thing about these colloids which are safe, when you're talking about colloids which are safe, you're talking about a degree of substitution which is very low, and you're talking about a molecular weight of starch which is very low, and that is how it is. You're trying to take away the side effects. But to me and to a lot of the scientific world, what happens is does it then have what it is supposed to do, the volume effect? If you're comparing the 130.4 in a balanced salt solution versus just a balanced salt solution that you have, the volume expansion that you get is not huge. I would have got in a the older starches. And so if it's not giving me that huge benefit, I would be, a little bit skeptical about using it.
Dr. Saikat?
Yeah.
One question from moderator side.
Yeah.
After giving the colloid or crystalloid, any changes in the gravid, large gravid uterus which causes supine hypotension syndrome? So
no, I think supine hypotension syndrome is clearly a mechanical thing. So whether you give crystalloid, colloid, the supine hypotension syndrome will only work if you are just tilting or you're just retracting the uterus or doing whatever. It has to be a mechanical reason to a mechanical phenomenon. It won't change.
Okay. Thank you very much.
So if I may just add one point.
Yeah.
So Dr. Saikat sir has mentioned about when we increase the safety of the hydroxyl starches with decrease in molecular weight and degree of substitution. One thing was improved about the substitution pattern. So earlier it was 4:1 substitution, now is 9:1. So these are the C2 to C6 ratio. It is the structure has changed with decreased molecular weight, but improved on the substitution. So that is why the volume effect is definitely maintained. So there is no decrease in the efficacy, but safety is improved. And one point about the crystalloid versus colloid. So definitely Fresenius has crystalloids as well and colloids as well. So depending upon the requirement, if it is surgery, when you're talking about the preload or cardiac output, definitely colloids provide that intravascular compartment. If the patient is of critically ill case where they cannot tolerate that thing or the requirement is to maintain the intracellular compartment, then definitely crystalloid are the fluids of choice. So that distinguishing, because like the diagram I showed about the compartments, so that distinguish just if we keep in mind, and whenever there is blood loss, definitely it has to be replenished and the colloids provide that solution. So that is just one comment from my side. Thank you.
Manoj, if I have just one thing. See, the good thing about obstetrics and in normal obstetrics and the complicated obstetrics, there are experts who will talk about it. The thing is, the physiology is such, you will be never chasing fluids or you will be never chasing volume. Should not be. So you will never be in a scenario where you will have to, pump in huge amount of fluids. Fortunately so. So the only place it can happen that you need to think whether I'm going to give fluids is when you have given a spinal, isn't it? So there will be a drop. And why is this drop happening? Are you leaking fluids? No, you are decreasing the SBR and causing this thing. So just treat that. Why are you trying to chase fluids where you know why this change in blood pressure is happening? So just correct it. I think I fundamentally therefore think that it is absolutely all right. Instead of chasing, because you're not going to do much because they're already in an hypervolemic state and the physiology takes care of that. That's it. That's what I'll say.
Okay, thank you very much to all of you. Nice presentation and a nice question answer session. So I request our next speaker, Dr. Nishant Sahai. Dr. Nishant Sahai is an additional professor at the Department of Anesthesiology, AIIMS Patna. His area of interest is BLS and ACLS, airway management, ultrasound guided regional anesthesia, and palliative care. His publication total number is 35 and 24 as in first second author, 12 original articles. His achievement is Professor T.N. Jha State Medal in 2008 and prizes Best Research Paper twice, an international paper presentation, 4 national presentation, and 10 organizing faculty in care WFSA, safe or workshop, IAPC, palliative care, course, AMF, airway, workshop, BLS and ACLS course. He is also my close friend, and under his guideline, our Bihar, Jharkhand, especially rising very well. In previous Bihar Jharkhand conference, he is very active scientific member, and he has done very well work. So I request Dr. Nishant Sahai to kindly present on your topic, eclampsia and preeclampsia.
Thank you so much, sir. Am I audible, sir?
Yeah.
Okay. So it is my proud privilege, sir. Thank you for the introduction. It is my proud privilege to present my views on preeclampsia and eclampsia, the basics. I am Nishant Sahai, and I bring greetings from AIMS in Patna. Just a minute, sir. Yeah. So in the plan for the next 20 minutes, sir, is that we will discuss and rush through the definitions, the clinical features, the diagnosis. We will discuss about some complications, basic management of eclampsia and preeclampsia, and I hope I have at least a minute to squeeze in a little bit about the anesthetic concerns of preeclampsia also, if it is possible, time permitting. Hypertensive disorders of pregnancy. Basically, it consists of 4 basic types. The gestational hypertension, and we need to diagnose what is hypertension in pregnancy. So the definition of gestational hypertension is defined as a systolic blood pressure of 140 mm or more and a diastolic of 90 mm or more, or both, on 2 occasions at least 4 hours apart after 20 weeks of gestation in a woman with previously normal blood pressure. So this is how we define hypertension in pregnancy. And if this occurs after 20 weeks of gestation, without features of proteinuria or other features of organ dysfunction, then it is known as gestational hypertension. Once proteinuria and other features of organ dysfunction set in, it is known as preeclampsia. And indeed, approximately 50% of women will develop severe will develop proteinuria or other end organ dysfunction consistent with the diagnosis of preeclampsia. What is severe gestational hypertension? Severe gestational hypertension is when the systolic blood pressure reaches 110 and the diastolic reaches 160, diastolic reaches 110, or both. But here what happens is that it precludes the requirement of having 2 separate readings 4 hours apart. Even if there are 2 readings 15 minutes apart of these 2 findings, 160 or 110, then it means that there is severe gestational hypertension. So what the postgraduates and we need to understand is the values 140, 90, 160, 110, etc. What is chronic hypertension? Chronic hypertension is defined as hypertension which occurs before pregnancy or before 20 weeks of gestation, and hypertension that persists for at least 12 weeks in the post-delivery period. This is known as chronic hypertension. And again, the values are the same. The total blood, systolic blood pressure 140, the diastolic of 90, 2 readings 4 hours apart. And in severe disease, it should be 15 minutes at least. There is an entity which is known as chronic hypertension with superimposed preeclampsia. And in a patient who has been diagnosed with chronic hypertension, if there is a sudden increase in the blood pressure that was previously normal, requiring an escalation of antihypertensive therapy, then this is, or there is new onset proteinuria or increase in the proteinuria, then it is said that preeclampsia is superimposed on the chronic hypertension. With a sudden increase in the blood pressure that was previously normal, requiring an escalation of antihypertensive therapy, then it is an echo, I think. Or there is new onset proteinuria or increase in the proteinuria, then it is said that patient was preeclampsia. Coming to the diagnosis of preeclampsia, preeclampsia group actually consists of 3 parts: the preeclampsia, eclampsia, and HELP syndrome. So we have basically seen the definition of preeclampsia. Preeclampsia, as we know, is a multi-system progressive disorder. That is what our obstetric teachers wanted us to wanted us to mention. So again, there is a blood pressure of 140/90, but here there is a classical association of proteinuria, and proteinuria of 300 milligram per 24-hour urine, or presence of protein creatinine ratio of more than 0.3, or a urine dipstick reading of greater than 2+, that will constitute preeclampsia. That will be diagnosed as preeclampsia. And in 2013, the ACOG, the American College of Obstetric and Gynecologists, removed this requirement of proteinuria from the diagnosis of preeclampsia, and they believe that if in a setting of hypertension, if there is any evidence of organ dysfunction related to all the major organ systems, like the hematological system, the liver, the brain, or the kidney, which can be characterized by evidence of thrombocytopenia less than 1 lakh, or serum creatinine more than 1.1 milligram%, or if the serum creatinine doubles, or there is an increase in the transaminase SGOT, SGPT level to more than twice the normal concentration, or there is any symptom of CNS, then in the presence of these end organ dysfunction, even without proteinuria, in the setting of hypertension, we can diagnose preeclampsia. So coming to what is preeclampsia with severe features, again, here the blood pressure is more than 160 systolic, and diastolic is more than 110. And these features are important because all our clinical investigations, all our history taking should focus on trying and elicit all the symptoms and signs of these organ system dysfunction. So we'll have to look for evidence of thrombocytopenia in the form of petechiae, purpura. We'll have to we'll have to ask for a history of persistent right upper quadrant pain or epigastric pain. Now this, certain ladies present to our PAC with non-specific abdominal pain, and we just give them proton pump inhibitors. We should be careful when doing that, because in more than 90% of patients with HELLP syndrome, they present with persistent right upper quadrant or vague abdominal pain, along with history of nausea and vomiting. Obviously, serum creatinine increases is important because most of the drugs require the renal route for metabolism and excretion. But one of the most important things that we should look for in history and examination is the evidence of CNS symptoms. It has been seen that in most of the patients who have had a bad prognosis with this disease of preeclampsia and eclampsia, especially with eclampsia, they had premonitory symptoms of photopsia, scotomas, cortical blindness, temporary blindness, but most important, severe headache. And most of them presented with headache before they had a convulsion. And even in autopsy finding, it was seen that most of these patients had cerebral hemorrhage. And even one episode of eclampsia has shown to have more than 20% damage of the white matter. So it is very important that by history and examination, we are able to elicit any symptom of the cerebrum, the CNS symptom. So at this stage, what I do with my postgraduate students is that I tell them that I have left out one major organ system. Which one is this? One major organ system I have left out for diagnosis of severe features, and that is the lung, and that is called pulmonary edema. So pulmonary edema is also a feature of severe preeclampsia. Coming to eclampsia, eclampsia is a convulsive manifestation of hypertensive disorders of pregnancy. It is defined by new onset tonic-clonic, mainly tonic-clonic seizures, but focal or multifocal seizures may also occur. Now, what is important is that we should rule out other causative conditions such as epilepsy, cerebral ischemia, hemorrhage, and drug use. And this becomes important if a mother presents with episode of seizure 2 to 3 days after delivery. And in these cases, we must rule out epilepsy and all these other conditions. HELLP syndrome. HELLP syndrome, we all know, is an acronym for hemolysis, elevated liver enzyme, and low platelets, and it is diagnosed by the ACOG when the LDH is more than 600, the AST, ALT are more than twice the upper limit, and platelet counts are less than 1 lakh. But what we need to see is that a majority of the patients, though they have hypertension and proteinuria, a significant percent of the patients, like more up to 10%, will not have hypertension or proteinuria, even though they have HELLP syndrome. So this is what we need to be careful about. Coming to the clinical features, we have already discussed most of the clinical features in the diagnosis. We need to elicit all these clinical features. Preeclampsia is mainly seen in the nulliparous women. It is there is a school of thought which believes that paternal antigen provides some protection against preeclampsia. So nulliparous women are more likely to be affected. There are other, in the 25% of the patients, there are vague symptoms like as mentioned earlier, headache, visual abnormalities, upper abdominal discomfort, and 85% of the patients present early, that is less than 35 weeks of gestation, and 10% present after 34 weeks of gestation, and 5% present in the postpartum period. So what is important is that in the presence of vague non-specific symptoms, we need to be very sure about the presence of risk factors. So there are a lot of risk factors in COVID patients, the most important of which is a history of previous preeclampsia. Apart from that, gestational diabetes, presence of CKD, obesity, chronic hypertension, these are major risk factors. And this is important because in certain patients where there's no clear cut or they fall in the gray zone, the presence of these important risk factors lead to starting of therapy like aspirin or even magnesium. And it is important for all the postgraduates also because they will be getting a long case of this preeclampsia, eclampsia. So in the history and examination, they must elicit and they must bring out as much of the risk factors in the patients as possible. So these are major risk factors. There is a lot of minor risk factors also. So based in the history and examination, they should bring out all the risk factors because it is clinically important also. Coming to the evaluation, again, when the postgraduates are asked or anyone is asked, how do you evaluate a preeclampsia? In fact, for that matter, how do you evaluate anything? Even evaluate the airway. We should always begin with a good history. We should take a good history, a proper physical examination, good, obviously blood pressure measurements in case of preeclampsia will be important. We need to get the lab investigations done and the basic lab investigations to rule out thrombocytopenia, to know the serum creatinine values, the ALT, AST, urine protein determination, that is important. And many times we are tempted to write the coagulation profile in such patients. But routine prothrombin time, PTT, fibrinogen levels are not indicated if there is no evidence of severe liver dysfunction or there is no evidence of bleeding or thrombocytopenia. So we should avoid coagulation profile. Apart from that, we must keep a note of the fetal status, which is done by the obstetrician. When should you send a person for neurological consultation? I have tried to stress it many times. If there is any problem, any abnormal neurological examination, if there are ocular signs or symptoms or persistent headache which is not responding to paracetamol, we should send them for neurological examination because there may be features of raised intracranial pressure. Regarding screening and recent advances in diagnosis, many people are measuring angiogenic factors, angiogenic and anti-angiogenic factors like tyrosine kinase and placental growth factors. But these are all in the experimental stages. They do not diagnose preeclampsia. They sometimes help in the ruling out of preeclampsia. And this is mainly done in combination with ultrasound. But this is again in the experimental stages. We need more data on these. Coming to the complications, there are a lot of complications that are there with preeclampsia and eclampsia, and they are broadly divided into maternal complications and fetal complications. So maternal complications, most common is severe hypertension and its related sequelae like cerebral hemorrhage. And there are biochemical abnormalities also. And there are fetal complications. So in a study which was done in 266 cases, what we can see is that the maternal complications of hypertension and biochemical abnormalities are the most common. Fetal also complications, there is a bulk of fetal complications, but eclampsia and abruptio form less than 3% of these complications of preeclampsia. So what is the management and how to prevent this morbidity? So we should understand that treatment of eclampsia and preeclampsia is termination of pregnancy. Termination of pregnancy, there are timings and this should be decided by the obstetrician. There are certain maternal indications. If the maternal indications are less than 34 weeks, we can think about trial of steroids for 1 to 2 days. After 37 weeks, again, the obstetrician might decide to deliver the patients. These are fetal indications, non-reassuring fetal status. These must result in immediate termination of pregnancy. Now, termination of pregnancy does not mean cesarean. You may give a trial of labor if the progress of labor is good, the presentation is good, the cervical findings are good. So coming to prevention, a lot of studies have gone on regarding nutritional supplements. Just like COVID, we are giving vitamins A, B, C, D, E, F, G, H, even garlic, sodium retention, restriction, everything, but none of them have shown to be demonstrate effectiveness. Drugs like sildenafil, metformin, etc. have been tried, but only one drug which has been shown to have benefit is low-dose aspirin. And again, as we mentioned, in patients who are at high risk, the low-dose aspirin should start immediately, even with one high risk. And with moderate risk, 2 or more moderate risk, if they are present, then you should start low-dose aspirin. There was another study which was done comparing low-dose aspirin versus high-dose aspirin 150. And they found that high-dose aspirin does not have any significant advantages. So seizure prophylaxis, this is important. The ACOG believes that magnesium is the drug of choice. The ACOG has good evidence that magnesium should be given to all patients with preeclampsia with severe features and also in all patients with eclampsia. And they believe that it is more effective than phenytoin, diazepam, and nimodipine. But what the ACOG is not very sure about is whether we should give magnesium prophylaxis to patients who do not have severe disease, preeclampsia without severe features. So there it has said that the physician or the institution should make their own protocols, and based on the risk-benefit ratio, they should decide the strategy. In most hospitals, again, what happens is if the patient has had any history of major risk factor, then they will start off with the magnesium prophylaxis also. So ACOG also believes that there is still sparse data regarding ideal dosages. Even the textbook dose of 4 to 8 milliequivalent per liter is questionable according to them. So what do the Americans do? The Americans give intravenous 4 to 6 gram loading over 20 to 30 minutes, followed by a maintenance dose of 1 to 2 gram per hour. And they started before onset of labor, and they continue for 24 hours after surgery. This is the same for vaginal delivery also. They should continue for at least 12 hours, 24 hours after delivery. If there is a difficult venous access, then they give intramuscular injection, 5 grams in each buttock, intramuscular, followed by 5 grams every 4 hours. And because it is a painful injection, some people mix 1 ml of Xylocard with the IM injection also. So coming to how do you give magnesium in a patient who is already convulsing? Now, there is a recommendation by the WFSA, which believes that in a combined IV and IM regime, in which they give 4 grams of magnesium sulfate over 20 minutes. And most of the time, this is sufficient. But if just in case if the seizures subside, then they give 2.5 grams into each buttock. But what happens if the seizure does not subside? If the seizure does not subside, then they give 2 grams over 2 minutes additionally. And if the seizure still doesn't subside after 20 minutes, then we will have to consider other drugs like diazepam or lorazepam. But the question is that whenever we ask our postgraduates, how will you manage eclampsia? Magnesium sulfate should not be answered. The answer is the initial steps in management of preeclampsia is the basic life support. The basic supportive measures call for help, prevent maternal injury, prevent aspiration and all that. Once the patient is stabilized, only subsequently attention is directed to administration of magnesium sulfate, because magnesium is because the seizures are short lasting. Maintenance phase is given only when the patellar reflex is present, the respiratory rate is greater than 12, and the urine output is more than 100 ml over 4 hours. Now, the concern is if there is a problem with the renal function. If the creatinine level is more than 1.5 grams or if the urine output is less than 20, then we should hold maintenance till you get good renal output, and we should measure the serum magnesium levels. If there are various things that we do once the creatinine levels are high, after 2.5 milligram%, it is not advisable to give a maintenance dose of magnesium. And if the high levels or the toxic levels are getting reached, then the frequency of checking magnesium level is reduced from 6 hours to 4 hours and up to 2 hours also in certain cases where the levels are very high. Magnesium is contraindicated in myasthenia, and some guideline measures pulmonary edema also as a contraindication. So if the magnesium levels are more than 9, we hold the infusion dose, and if it is reaching 12, then we give 10 ml of 10% calcium gluconate over 10 minutes, and it can be given over 3 minutes also. But if it is life-threatening or if there is features of severe respiratory depression and there is a peri-arrest situation, then up to 30 mils can be given over 5 to 10 minutes. Coming to the antihypertensive therapy, in the acute stages, the drug of choice is labetalol. We can give hydralazine and nifedipine also. In the acute stages, these are the doses in which it is given. Now, the concern is whether we should give, this is when the blood pressure is more than 160. But whether we should give antihypertensive to non-severe patients is a matter of debate, because the antihypertensive drugs might have their own side effects. And one approach is to consider the potential risk of developing severe hypertension to starting the antihypertensive therapy. I was hoping that I could have one slide of anesthetic management, but I feel my time is up. So the resident should know that if a case of preeclampsia is given to you, these are the 5 or 6 black holes that you can be sucked into. And you will be asked questions. You can be taken into any of these directions. I bring greetings from AIIMS Patna. I thank you for your patience hearing.
Thank you, Dr. Nishant for nice presentation. You are elaborated pre-eclampsia, eclampsia in a very nice way. So I request our next speaker, Dr. Swagata Tripathi. He is presently designation is additional professor at AIIMS Bhubaneswar. Major achievement is MD Anaesthesia medalist from PGI Chandigarh, and fellowship in Neuroanesthesia and Neurocritical Care, Liverpool, UK in 2010 and 2011. Awards and is European Diploma in Intensive Care in 2012, Indian Diploma in Intensive Care in 2011, in charge Central ICU and course coordinator PDF Critical Care, AIIMS NGIX Inaugural Challenge Award winner in 2019, extramural funded project in critical care 3 times, intramural funded project 1, educational grant award in NGIX Singapore 2017, test paper ISACON 2016 and 2019, ISCCM 2018 and 2019. PubMed index publication is about more than 40. Book chapter with international publication is 6. So very nice biodata of the Dr. Swagata Tripathi from AIIMS Bhubaneswar, and she will present on sepsis in pregnancy. So I request Dr. Swagata Tripathi, you are very close to me also. So kindly proceed.
Very good evening to all of you. And I've been on screen. I'm actually on COVID duty, so you can see I'm looking really tired, and probably you can still see the mask marks on my face. I just want to know if, how do I get my presentation on screen? Yes, that's there. So yes, once again, a very good afternoon, and thank you for giving me this opportunity. Special thanks to you, and Dr. Manoj, Dr. Saikat, the team of Fresenius Kabi, Sumana, who have borne with me. I just sent in the presentation. At an outset, I'll make a disclaimer that this is not going to be a very detailed discussion of either pregnancy or sepsis, but it will be more of a hands-on, pragmatic dealing of sepsis in pregnant patients. The only time I have had the opportunity of working closely with pregnant sepsis people is during my training in PGI, where they have a separate ICU for pregnancy, and then you see a lot of these patients. But fortunately or unfortunately, in most other places, you have an ICU and the pregnant patient comes in to you, either before or after pregnancy. What is important to note here is that the best definition of sepsis and pregnancy probably only came in 2017, and that is why perhaps it was not given so much of importance. So the WHO called it the consensus definition that it is an organ dysfunction which results from infection during pregnancy, during childbirth, post-abortion, or in the postpartum period. So it's a very diverse conditions around pregnancy. If you get infection there, then and you have an organ dysfunction, then you have sepsis, which may further lead on to septic shock. So the objectives in the next 15-20 minutes, and again I reiterate, I'm going to keep it very bedside, will be to highlight the difficulties in diagnosing sepsis in a patient who's pregnant or peri-pregnant, like I just said, the WHO definition, to highlight some of the updates and some new definitions which again somehow conveniently miss the pregnant patient, and finally highlight the controversies in management of sepsis in a pregnant patient. What is important to understand is pregnancy is a normal condition, but as we heard Dr. Sengupta say, it's definitely not normal. There is a huge shift in homeostasis, and that is one of the major issues that we have to deal with when these patients come to us with infections and sepsis. The changes we have just heard Dr. Saikat say, but the impact of the baseline changes which affect us when they come to us with any infection are very important to consider, and we'll just see practically how they affect us. So we know that the cardiovascular system, there is a decreased arterial pressure, increased heart rate, and increased cardiac output. But because of this, when there is an add-on infection and vasodilation, these patients will have an increased risk of hypoperfusion and thereby an earlier organ dysfunction than, say, a 20-year-old woman who's not pregnant. So a high suspicion has to be there in your mind to think that if she's pregnant and she is hypotensive, she has a greater chance of hypoperfusion. An abnormal baseline may mask signs of sepsis. The GI tract, there we know that there would be a delayed gastric emptying and the tone will be less, so the chance of aspiration pneumonia would be higher. The chance of any airway intervention you do, we all know as anesthetists that intubation is difficult. In sepsis, it becomes more so, especially with the respiratory changes, when hypoxia can be very quick to manifest, and any hypoxia will also affect the fetus. Coming to the hematology, the changes that have been already discussed, the physiologic anemia would result in a decreased oxygen supply to the tissues, and the DIC would manifest much earlier in a pregnant patient than it would do in somebody who's of the same age and otherwise physiological status but is not pregnant. An important difference in when you're pregnant is that the TLC is usually higher in all the peripartum conditions that we have just mentioned, including just in the last talk, if a patient is eclamptic, the TLC could as well be 25,000 without having any infection. So it would make it very difficult for the clinician to think whether it is an infection, whether it is just inflammation due to the eclampsia. So the TLC rise, which is normal in pregnancy, can lead to a lot of confusion. And finally, the renal changes we saw, the dilatation of the ureters, increased vesicoureteral reflux, and increased the renal plasma flow. Usually, their urea creatinine, the creatinine levels are lower than normal. So if a young woman of 20 who's not pregnant, a normal creat would be 1.2. For a pregnant woman, it would be 0.8. And from 0.8 to 1.2 is a big leap. But seeing 1.2, you may miss to catch the fact that already acute kidney injury has started in this septic pregnant patient. So the point that we are trying to make is that due to this homeostasis shift, picking up Sepsis is delayed and is difficult. Diagrammatically, the same thing, just to make it very pictorial and very stark. On one side, you have pregnancy, the other side, you have sepsis. The same four systems, the cardiovascular system, similar changes, the respiratory system, again, similar changes, the renal, the increased renal plasma flow or the GFR, they can mimic what will happen and worsen the effects of sepsis. And we just mentioned the coagulation. So what happens? The interplay of the sepsis and pregnancy leads to a cumulative effect of a rapid hemodynamic collapse. It makes the pregnant woman more susceptible to pulmonary edema. There is rapid decrease in oxygenation. The FRC is less. So you would not be expecting the hypoxia that would happen very suddenly when you're trying to intubate or you're trying to shift over from mask to NIV or just remove the mask for feeding. The desaturation will be rapid. Adult respiratory distress syndrome is more prone to occur quicker, and they will have a decreased ability to compensate for metabolic acidosis because it is a stage of metabolic alkalosis is the physiology, so they cannot easily compensate for the new acidosis. In the renal, the acute renal injury or the kidney injury is more, it's easier, like they are more susceptible to acute kidney injury. And we spoke about the DIC, which is much more frequent and more scarier in this group than otherwise, and tissue hypoperfusion, end organ dysfunction. Pregnant patients are also very susceptible to thrombophlebitis and deep vein thrombosis, embolization due to the deep vein thrombosis, or the pelvic vessels get thrombosed. So this is how there is an interplay between pregnancy and sepsis. The next thing we will be speaking about is shift in diagnosis. We saw how the two interplay and make it difficult to diagnosis. So where comes the shift, and where in the whole timeline of pregnancy should we be careful? So when we look at what are the infections that usually bring a pregnant lady to us in sepsis, there are a few, and they would have a typical time frame when they occur, and this would help the clinician to kind of point or put a finger on what to think about. So the infections that are common are the pelvic inflammatory disease, and these are more common in the first trimester. The appendicitis is very common, pyelonephritis, pneumonia, and endometritis. The pelvic inflammatory disease, more often in the first trimester, you can evaluate it with an examination or a transvaginal ultrasound and evaluate for a tubo-ovarian abscess is suspected. Now, thankfully, most of this, the obstetrician would have done, they will hand the diagnosis to you on a platter, and then you can take it and start the treatment for the sepsis. Appendicitis, on the other hand, is something that happens on the second trimester more commonly. And at this time, it's a young, apparently healthy woman who comes to you, and she may have very vague complaints which are nothing like appendicitis that you've read of in your surgery classes when you were in your MBBS years. So what happens is the uterus pushes up the intra-abdominal organs, and the appendix is no longer in the right lower quadrant. It may be somewhere up in the right upper quadrant. The pain may be very different. 45% of the patients who have, pregnant women who have appendicitis, actually complain of tenderness in the rectum. So we can understand how difficult it will be to think of appendicitis when there is tenderness in the rectum. Add to it the fact that there will be nausea, vomiting anyway in your pregnant patient. So the nausea, vomiting of appendicitis is masked. The TLC that is risen in appendicitis will anyway be there physiologically in the pregnant patient. So what do? Again, a low threshold for suspicion. Do an ultrasound. If it is still equivocal, do an MRI. It is important to diagnose the appendicitis, because if the diagnosis is late, studies have shown scientifically that the mortality may go up, 28-day mortality actually may go up from as little, from 21 to almost 45%. Pneumonia can happen in any trimester. We know chest radiograph is not very safe, so an ultrasound will help a lot in the ICU nowadays. and avoiding the X-ray. The antibiotics, as is safe for the fetus, will have to be given, and always keep in mind that a good management of the oxygen levels can keep the baby safe as far as possible. Endometritis usually happens in the postpartum period. By now, you can easily do a CT scan and diagnose this, and it is the endometritis with the thrombus of the vessels in the pelvis. Both of them can be very debilitating, but picked up very easily in a CT. So keep that in mind. So this would be what are the causes of sepsis in these patients. Moving on, how do you diagnose sepsis in the bedside? So there are so many consensus definitions of sepsis, but unfortunately what happens is most of these studies do not look at pregnant patients. That's an exclusion criteria. They haven't studied these things in a septic patient. So the evidence base for sepsis in pregnancy and early diagnosis of sepsis in pregnancy is very less. So this table here is one of the scores that had been brought out to think of or pick up quickly sepsis in pregnant women. So it's an obstetric modified early warning system. Unfortunately, don't go too much into detail, because when they tried to validate it, they found that the validity is very less. The sensitivity, specificity is extremely poor. So it's not, and it varies from situation from the low-income countries to the high-income countries. It was varying. They could not really validate it. So it's not being used very commonly. I would like to bring your attention to the simple Q-SOFA score, being an intensivist. So the Q-SOFA score has now been slightly modified to fit into the obstetric patients. So if you look at this in a normal Q-SOFA, I wonder if you can see the arrow here, I'm not sure. But if you look at the systolic blood pressure, a score of 1 in normal Q-SOFA would be if the SBP is less than 100. And a respiratory score of 1 would be if a respiratory rate is more than 20. So it is modified in the obstetric patient to read less than 90 and more than 25, keeping in mind their physiological changes. So this obstetrically modified Q-SOFA score is something you can use in the bedside to think about whether you want to shift the sick-looking pregnant patient or peri-pregnant patient to the ICU. You can also use these very simple pragmatic indications for transfer of the patient into the ICU. Hypotension, raised serum lactate despite fluid resuscitation. Now here again there is a point, how much raised, because serum lactate is diluted in them. So usually in the sepsis consensus definitions it would be a lactate of 4. Here it can be even as low as 2.2. So it has to be a combination of things, and the decision is not really very evidence-based, but probably would be experience-based. Respiratory, if the patient has a pulmonary edema, requires mechanical ventilation or airway protection, definitely needs to go to the ICU. Renal dialysis, not only for renal dialysis, but if there is an accompanying, let's say, a high chance of a pulmonary edema due to low urine output, then yes, the ICU shifting is important. Change in consciousness level, perhaps harming or risking the airway protection, that would indicate a shift to the ICU. And of course, multi-organ failure, uncorrected acidosis, and hypothermia. So this is the SOFA score. The SOFA score slightly modified in obstetric. This is the obstetrically modified SOFA score. You can see, of course, that we don't have 4 and 5. The normal SOFA score is a little bigger and more extensive. They have simplified it over here. It is almost similar, except for the renal parameters come down to the last row there. The only thing that is different in the obstetric versus the non-obstetric SOFA scores or sequential organ failure scores in sepsis is the creatinine. As I just said, the creatinine would be lower in patients who are pregnant. What are the changes in resuscitation and management of these patients? Again, staying very pragmatic, the Critical Care Society recommends an initial bolus of 30 ml per kg for patients within the first 3 hours for the initial resuscitation. In obstetrics, it has been modified to 20 ml per kg because of the higher chance of developing pulmonary edema and the already higher intravascular status that they would have. So you start giving crystalloids. Again, there is no debate here whether you want to give crystalloids or colloids. Resuscitation is always crystalloids, and it is 20 ml per kg for the pregnant. I spoke about the lactate. Yes, present recommendations of the RCOG, that is the Royal College of Obstetrics and Gynecology, is still more than 4, but they recognize that even less than 4 could be a criteria in many circumstances, or a MAP of less than 65. And to always remember source control. It is in pregnancy, sepsis, source control is extremely important. Like we just saw the table of the causes of sepsis in pregnancy, many of them can be located sources. So a decrease or a delay in source control, like I said, would really increase mortality. Septic shock is complicated, and very simply put, it can lead to vasodilation on one hand, leading to tissue injury, and on the other hand, to cardiomyopathy and cardiomyocyte death. Somehow, the cardiac effect of sepsis in pregnancy is more than what you would otherwise see in a non-pregnant, otherwise similar patient, and that is something that we need to remember. A little bit more, we are near the end of what I have to say today, is to talk a little bit about the controversies, a little bit about the many controversies actually, because like I said, the evidence base for sepsis in pregnant patients is not great. So the controversies start from the very beginning for selection of the patient to initiate the sepsis bundle. Again, patient is in labor and has fever, well, the TLC would be high, and the causes of fever can be many, starting from a prolonged labor in a hot room to epidural analgesia that you have given. So that has to be kept in mind. They will be tachypneic, they will be tachycardic, the effort of labor itself will make them tachycardic. Glycemic control, a very strict glycemic control is not acceptable in the pregnant patients because of the considerations of the baby. But anyway, the whole world of intensive care has moved to a much friendlier glycemic control of 150 to 180. So that sits very well with the pregnant patients as well. Steroids, they say only for septic shock. The RCOG does not tell you to give steroids, but in any case, steroids are given for fetal lung maturation or for other diseases like SLE. The only evidence here is that if you give too much of steroids too frequently during pregnancy, the chances that the fetus will be underdeveloped are higher. So one needs to be careful there. Oxygen, like we said, the risk of desaturation is much higher. So instead of the PaO2 of 60 that you would like to have, probably in an adult non-pregnant patient, would become a PaO2 of 70. I would just like to talk a bit about the ABG. You need to be a little careful about interpreting and...
Dr. Swagata.
Sir, am I out of time?
Dr. Swagata.
Yes, sir.
So, yeah. So,
okay, so yeah, then I'll really wrap
please,
up. So the vasopressors and inotropes remain the same, and when we come to very hi-fi treatments like ECMO, IVIG, or Enomics in pregnancy, it all falls flat. The fast hugs BID is still the best thing that you could do for your septic patient. And my last slide, we know, or we have discussed, it is a leading cause of mortality. The pregnant women are most susceptible to deteriorate rapidly. It has a complex pathophysiology which is affected by the adaptations of the pregnancy itself, and the physiologic changes mimic those of sepsis. And early recognition and optimal management is important. And there are many recent updates, and one has to keep track of them. Thank you so much.
there is lots of questions.
Oh, really?
Hello.
Okay.
Lots of questions. Dr. Nissan.
Sir.
For you.
Sir.
How much it medico-legally safe in not doing prothrombin, INRH, and APTT in normotensive patient?
Okay, thank you, sir. The question is how much is it? Right, sir. So the question is how much is it medico-legally safe in not doing PT, INR in normotensive patients, right? The question, sir, is PT, APTT in a normotensive or non-normotensive patient, it doesn't matter. What matters is whether the patient is showing any signs of bleeding or any signs of liver dysfunction. If there are no signs of liver dysfunction, there are no evidence of bleeding in an ASA1 patient, then routinely, even in the NICE guidelines, in an ASA1 patient, routine PT, INR, APTT is not required. But yes, if there is a patient who is going for who has a severe preeclampsia, features of severe preeclampsia, eclampsia, who is going for emergency cesarean, then it might be justified. If at all there is any doubt in the mind of anybody regarding the liver functions or the coagulation profile, then he is well advised to get it done. Normally, if the platelet levels are normal, there is no evidence in the history and examination of any particular hemorrhage, then most likely it will not result in any major significant problem either. So medical legally, yes, you have to be safe if there is evidence of bleeding or there is evidence of a problem with the coagulation. But in a normal routine normotensive patient, you are perfectly medical legally safe in not getting the PT, APTT and IRNR done. That is given in the NICE guidelines also.
Second question from Arpita Ghosh. Low dose aspirin, what to do who are below 35 weeks with sudden eclampsia, symptom needing immediate LSCS. You can also see on the chat back.
Right, sir. So Arpita has asked regarding low dose aspirin, what to do who are below 34 weeks. If there is eclampsia, sir, is an indication for immediate termination of pregnancy, and she herself has mentioned that there is an immediate cesarean section that is about to take place. So low dose aspirin does not interfere in any of the anesthetic management of cesarean section. With low dose aspirin, we can give neuraxial blocks. Regarding whether we should give aspirin, obviously when the cesarean is about to take place, there is no role of low dose aspirin after that. But I'm assuming that patient might have been on low dose aspirin and for cesarean, so there is no problem with low dose aspirin and surgery. And once the delivery is done, then obviously it will not be required aspirin.
Oh, thank you very much. Due to shortage of time, we cannot ask lots of questions. And nice presentation by Swagata Tripathi, madam. Our next speaker is from ISA Bihar Jharkhand, Dr. Asif Ahmed, who is a senior consultant and the head of department in the Department of Critical Care Medicine at Tata Main Hospital. He is the Associate Dean at Manipal Tata Medical College. A DNB in Anesthesiology, awarded gold medal at IDCCM. He is teacher and faculty in DNB Critical Care courses. He has more than 100 publication, presentation, lectures, including previous awards. More than 20 publication, including books. So he is my close friend from Jamshedpur. I request Dr. Asif Ahmed, who will present on the maternal mortality and the cardiac arrest. So kindly proceed, Dr. Asif Ahmed.
Good evening, ladies and gentlemen, and thank you very much, Dr. Manoj. Very nice of you for having me come in for this webinar. Thanks to you, Dr. Saikat, and the whole organizing team. At the outset, I would like to thank each and every one of you, and greetings to all the people who have been here for this webinar. Greetings from Tata Main Hospital. So today we're going to discuss about the maternal mortality and cardiac arrest. So before that, if I have to ask each one of you, have you ever tried flying around the world? Do you have any information about it? People have done that in a single stretch. And this was the flight.
Dr. Asif?
Yes.
Dr. Asif, आप प्लीज मास्क हटा के बोल सकते हैं?
Thank you. I would have loved to do that, but the problem is I am in a situation right now, and that is still with a lot of dangers and risks. So if I'm clear, it's fine. Otherwise, it would have been a really something.
आपका आवाज जो है इको हो रहा है.
Is it echoing still?
Yes.
Is it better?
Some better.
Yeah, okay. I'll come closer to the laptop. Maybe not about the distance here. So I think this is better. Dr. Manoj? Fine, thank you. So,
okay.
So we have talked about a flight which takes almost 53 hours to go around the world. And then if you are just asked to go around the world in 20 minutes, that becomes quite difficult and impossible, but still you'll have to make it. And this 20 minutes is that theory that you have to conduct here on the small talk that you are going to have on maternal mortality, because this is something that's being very widely studied, discussed, and it takes a lot of time understanding the whole situation. But as per the requirement, the next 20 minutes.
Your voice is also not heard properly, not heard by all of you.
Okay.
So if your mic is under.
I'll just do that.
Mic very close to your.
Yes. So in the next 20 minutes or so, we are going to discuss about the maternal mortality and cardiac arrest. What is the magnitude of the problem? What are the causes and the prevention that can be applied? And what are the guidelines of the literature say about it? So first is to understand what is maternal mortality. This is defined as the death of a woman during pregnancy and up to 42 days after delivery or termination of pregnancy, provided the cause of death here is related or aggravated by the pregnancy or its management. So it's important that it has to be related to pregnancy. Now, at the same instance, we also need to understand what is the maternal near miss. Now, these are patients who nearly died but survived a complication that occurred during pregnancy, childbirth, or within 42 days of termination of pregnancy. So, if you have to understand this, a maternal mortality has an incidence of 1:12,000 to 1:36,000, whereas a maternal near miss is as low as 1:141 cases. It was a study that was reported from Germany. Out of these 141 cases, every 53rd patient can have a fatality. So we have to also take into care that whenever we're dealing with such maternal mortality or some situations, the maternal near miss has to be taken into account. So if we have to understand what does the World Health Organization say? Now this review report over the last 2 decades showed that in the year 2017, when the last report was on, that almost 140 million births are happening every year. And out of that, 810 mothers are dying every day. Now, this was a matter of concern all over the world, but over the years, in fact, the last 2 decades, what has happened is the deaths have been brought down significantly by 38%. But the important factor that remained here again was that 86% of global deaths in 2017 were in areas that belong to Africa and South Asia. Now, as you can see in this diagrammatic representation here, which shows the worldwide map, the areas which are shaded in dark are the ones with the mortality rate. So we can easily say that it is high in areas which belong to Africa and Asia. But I know that in the last few years, all of us have seen a lot of efforts being done, and there has been a change in down. Now, that is what the aim of the WHO is, and our country is also Sustainable Development Goal is an average global ratio of less than 70 deaths on 1 lakh births. We are working on that. Each one of us has to contribute. Now, a review of the different other places. This review was done in America, United States of America. All cardiac patients happened between the year 1998 and 2011, and they found that the cardiac arrest incidence was 1 in 12. The most important factor was
Asif,
yes, Dr.
sorry
Manoj.
for interruption.
Yeah.
Your voice is not clear, so you can take mic near to mouth.
Yeah.
Going your voice.
So I think, okay, I think maybe signal. But can we have the feedback from others, Dr. Manoj? Is it clear to others or not?
So there's a muffled sound which is coming and it's echoing.
Sorry?
There's a muffled sound which is coming.
Okay.
So the audio quality, we are not able to hear properly.
Okay, we'll try to. Okay, thank you. So is it better now?
Better.
Much better.
I think I need to speak very close to the laptop. Yeah, I'm sorry for that inconvenience earlier. So this study, which was done in America, showed that cardiac arrest was 1 in 12,000. The intriguing factor here was that 58% of these patients survived. Major causes were hemorrhage, heart failure, amniotic fluid embolism, and sepsis. Now, this is another study that was done in the United Kingdom. This was published in 2017. This was a prospective descriptive study. It was using the UK Obstetric Surveillance System. They studied all pregnancy patients in 2011 and 2004. And the main outcome of the study was to find out the cardiac arrest of pregnancy, the perimortem cesarean section, which has come about as an important step in managing these sections, and the maternal. Now, they found that they had almost 66 cardiac arrests in pregnancy over the last few years. Here, the incidence was 1 is to 36,000, which was much better than the 1 is to 12,000 that we had in the United States of America. But the important factor here again was that 58% of these patients will be salvaged. Now, this was quite easy compared to the patients who were in the non-pregnant state who had an arrest. Here, the outcome figures were quite good. And the important factor again here was that 16 women who arrested solely were because of obstetric anesthesia. So that was important. And perimortem cesarean section was performed in 49 people. And here the success rate was quite high, with 46 out of 58 babies, which were delivered as a result of this perimortem cesarean section, were born alive. So these are some of the very appreciative features which can say that if we properly take care of the resuscitation in maternal category, we can result in good outcome. Now, what are the different causes of maternal cardiac arrest? Well, if we have to put it, this will figure time and again. It is cardiac disease, it is septic shock, it is amniotic fluid embolism, it is severe preeclampsia, eclampsia, and hemorrhagic shock, which we have discussed in detail in the last few presentations. This study showed what was the incidence of the causes that could have led to a maternal arrest. But there are certain mnemonics also which have been put up by different authors. Now, this talks about bleeding, embolism, complications, decline and turning, cardiac diseases, eclampsia, and others like bleeding causes like rupture or sepsis. So whatever we put it, there were other synonyms also, like the one which is used and called as ABCDE UPS, but all of them are actually used which bring about the different common causes regarding the cause of this maternal cardiac arrest. But what we need to understand as anesthesiologists and intensive care, that 25% of maternal deaths happen as a result of obstetric anesthesia, and these were related to drug toxicity, cause of local anesthesia. We had drug overdosage, we had high spinals, we had anaphylaxis, we had aspiration. So 25% of these deaths were attributed to because of anesthesia. Now, if we have to understand, is maternal cardiac arrest different from other cardiac arrest? Well, the answer is yes. Now, why, if we have to know? Well, then, this is a situation, it is not just about dealing with a patient who has had a cardiac arrest, you're dealing with both the mother and another life, which is that of the baby. And we have a lot of physiological differences in pregnancy which need to be understood. And that was the reason that the earlier deaths were because of the knowledge deficit and the poor resuscitation skills that people had when they were dealing with maternal cardiac arrest. If you have to understand, I'm not going to spend much time in here because we have discussed, but I think a quick review should be. So we have seen that the cardiac output increases by almost 30 to 50% in all these patients. Vascular risk and mean arterial pressure. Other important factor is the increased after load and a decreased return, which primarily affects the cardiac output. And this happens because of an enlarged uterus, which is normally seen at more than 12 weeks. And this is a result of the compression of the aorta, and the compression of the inferior vena cava, which is very common in patients who are in the supine position. So it has an implication when we have to deal with these patients with cardiac arrest. So another study that was a study that showed that once we had a cardiac output done in a lateral position, which had seen an increase in cardiac output by almost 25% as compared to the supine position. But again, the feasibility of the lateral position is to be understood because if you make a tilt of more than 30 degrees, then that can cause really physical problems and the patient might slide down or you might have difficulty in and of the airway, or even performing the procedure of cardiac compressions when the patient is in the lateral position. Now, 20% increase of the maternal cardiac output is also there, which takes almost the uterine blood flow increase. And any hypotension with the compensating mechanism already overwhelmed can be dangerous in these patients. The respiratory system takes a big hit. The functional residual capacity is decreased by 10 to 25%. The minute ventilation increases because of the diaphragm as well as because of the hormonal changes. There is can I request others to kindly mute their mic, please? So there is a mild respiratory alkalosis, and along with that, there is a may I request others to kindly mute their mic? Yeah, thank you. And the oxygen consumption, which has increased here, can be a demand which can lead to severe and rapid hypoxemia whenever these patients are compromised with cardiac arrest. The renal system, the hyperrenal flow, and the glomerular hyperfiltration can lead to increased tendency of developing pulmonary edema because of the high oncotic pressure. And finally, the gastrointestinal system has an increased risk of aspiration because of the hormonal changes leading to relaxation of the sphincters and prolongation of the intestinal tract time that is delayed. Having understood this, we need to now understand or identify those people who are at risk and then prevent the happening of cardiac arrest in these cases. Now, it's very important that all pregnant women who become ill be stratified by a validated objective early warning score. Now, that we have seen in previous presentations, the different scores are there, the modified early warning signals, the SOFA scoring, SOFA scoring. But what is important that for obstetric patients, all these have been modified. Now, this is one example which was developed by colored coding warning, which incorporates 6 parameters, which includes the systolic blood pressure, respiratory rate, it has a heart rate, it has a FiO2, which is required to maintain a saturation of more than 96%, the temperature that this patient has, and the level of consciousness. All these parameters, if we find that the score is more than 6, it has both the pluses and minuses. If we find that the score is more than 6, then it warrants admission and monitoring. This is the time when a rapid response, a quick appreciation, and early recognition is warranted for preventing these patients from going into cardiac arrest. Now, these patients should be treated very rapidly, as I've told. Optimization of hemodynamics is of importance in all these patients, and the hypoxemia which can develop rapidly. Now, here the basic is that you need to always put the patient in the full left lateral position, or you do a time lateral by using a wedge, by doing a manual displacement. Oxygen should be administered 100% by the face mask. Intravenous access for fluid resuscitation always be done in the upper limb. And you need to look and see the precipitating cause apart from the previous patients. Now, what do the guidelines say in managing this cardiac arrest that we have in the maternal case? Go quickly through this. This is based on the AFA scientific statement which talks about cardiac arrest. And here we have to understand that what are the key steps which should be taken into account whenever we are dealing with cases. The first responder, whoever it is, to have knowledge of whatever the physiology of pregnancy, because these are patients who are anatomically challenged and physiologically compromised, and they are at the brink of. The core team members should be properly trained, have experience, and staff that is also important. And the hospitals should ensure that there is a pre-event planning and plan for management. So whenever you have a maternal cardiac arrest, there's not much compression ventilation at a ratio of 30, and the interruption should be minimized to 30 to 10 seconds for any intervention that you have to do. But what is important that this procedure of resuscitation should be done in a supine position, and mechanical compressions are not recommended. What is important is high quality CPR with a lateral uterine displacement. As you can see, it's not about putting pressure on the uterus by increasing the pressure on the uterus with an abdominal arm again. It should be actually a lateral displacement. It can be a single hand technique or by using the double hand technique from the other side. So whatever it needs to be applied and done continuously. Defibrillation should be done rapidly. There should be no delay or difference in the management here. And all these patients, because the progression of rapid hypoxemia and deleterious outcome is pretty high, they should be ventilated with bag mask with 100% oxygen with a minimum flow of 15 liters per minute. And it should be preferably two-handed bag mask, which should be done. And whenever we get a ACLS team, and we have a team which should include an obstetrician, we should have an anesthesiologist, and we should have a pediatrician. Whenever the team is available and trained people are available, then we should go in for the ACLS support. Hypoxemia, as we know, is a major cause here. So early ventilation support and intubation by an experienced personnel is warranted. It should be done by the trained
Dr. Asif,
Yes.
please
Yes.
bind up.
Yes,
There is
Dr.
lots of. Please bind up.
Yes,
There is
sir.
shortage of time.
Yes, I'll do it right on time. Just give me 2 minutes. Thank you. The cricoid pressure, which is normally recommended, is not to be done routinely. The aorta caval compression here should be a continuous manual left uterine displacement, which should be performed continuously in all patients. And it should be done in all patients where the uterus is felt at the level of the umbilicus. The positioning of the hand. Earlier studies had said that the hand should be placed higher in patients who are pregnant, but here there should be a hand placement which is normal as for all other patients. It should be done because there is no scientific evidence. And patients here who have had a cardiac arrest should not be transferred to either the operation theatre or to any other facility inside the hospital, because the time lost is of paramount importance, and it should be done at the site of an intervention like a cesarean delivery should be done at the site. Now, talking about defibrillation, we should be using anterolateral pad placements. The lateral pad should be put under breast tissue, and there should be a put in there. Now, the quick to 1 minute I'm just going to spend on the peribottom cesarean section. Here it talks about the birth of a fetus after maternal cardiac arrest, most commonly during resuscitation. In this case, the purpose is resuscitation of both the mother and also of the fetus, only on 4 minutes. There are several reports about the return of spontaneous circulation with your perimortem cesarean section, and if it's not done, both the people can die. So it's very important that we do this. So it is to be done whenever we are unable to have a return of spontaneous circulation within a period of 4 minutes, and that's the time when we should be going ahead with the perimortem section. Now, it is not that this assisted vaginal delivery cannot be done. It should be done in cases where the cervix is fully dilated. And in situation or places where there is no facility, and you can also transport to other centers where this facility is available, but the transport time here should be less than 10 minutes. It's quite impractical, most of the situations. You have to have equipment readiness for resuscitation. I'm not going to go into the details, but this should be available at all hospitals. And not to mention post-arrest care and the medico-legal implications, because we should be very clear with our documentation, with our measures that we have taken, the analysis of cases, and what are the corrective measures that are taken. So to summarize, so in these special category of cases, proper overall knowledge, good teamwork, a good equipment and its preparation and availability, and a proper implementation of whatever has been planned, along with early aggressive resuscitation, can give us a lot of benefit. Thank you.
Our next speaker is Dr. Kaushik Das Gupta, sir. Dr. Kaushik Das Gupta is a graduate and postgraduate of the Medical College, Kolkata. He is currently consultant in ISS UK. He is leading consultant in obstetrics and regional anesthesia. His topic on the labor analgesia, what is new. So I request respected Dr. Kaushik Das Gupta, sir, kindly proceed, sir.
Thank you. Thank you, Dr. Manoj. Start the slide.
Thank you, sir. Welcome, sir.
Yeah. Can you hear me, everyone?
Yes, sir.
Yeah.
Yeah, yeah,
So
yes.
it was a long. Hello. You can hear me, everyone? So I'm Dr. Dashgupta. I'm going to speak about labor analgesia update. It was a very long evening. It was very good presentation. We learned quite a lot. So it's the last bit of a sandwich. The top sandwich was Sengupta and the last sandwich was Dashgupta. So I will start with it. So update means some recent advances. So this is my journey as a doctor. So you can see I started from Medical College Kolkata and ended up in this hospital in UK. The address didn't update. It was the same address. Epidural labor analgesia didn't update that much in 80 years because the philosophy, the physiology, and the anatomy all stayed the same. I will go through some of the recent advances and why things have changed and how we should look into the next 10 years in labor analgesia. We all believe that the only thing women should feel at birth is joy, and that is the most important thing. They don't remember even if they felt pain during the labor. They just get a bundle of joy in form of a baby, and they are very, very happy. I will go through the definition of labor is the cervical changes because of uterine contractions. So uterine contractions is an important thing, but most changes happen distally towards the pelvic structures. So we are more concerned with the sacral nerve roots and the analgesia lower down rather than the lumbar plexus or all those other nerves that are on the top. It has 3 stages, as we all know. The first stage is up to the complete dilatation of the cervix, and then the second stage is up to the delivery of the baby. The third stage is not that important for labor analgesia. When I searched the Google that what moms search in the Google, the first thing they search is does the epidural and the neuraxial analgesia slow the labor down? What effect it has on the baby, and does it cause paralysis? So my outline of the topic will be initiation. We all know about the conventional epidural. Are we trying to move towards the newer neuraxial analgesia in terms of CSE, combined spinal, or a DPE, dural puncture epidural? We encourage more and more use of ultrasound. In the maintenance of labor analgesia, we are trying to move away from manual bolus and continuous infusion to more giving more autonomy to the patient in form of patient control epidural anesthesia. We should use least amount of the concentration of local anesthetic to prevent motor block. We should use new designs of catheters. I will come to it later on in the slides. And there is always if there is a contraindication for epidurals, should we use other opioids like ultra short acting remifentanil, and we should abandon the test dose. So these are the updates, and I will come through all the slides. I will try to stick to the time. Anatomy update. Teaching my trainees, I felt that they do 2 things. That remember that the veins and the vessels, the Bateson's plexus, are all in the anterior epidural space. We are only concerned with the posterior epidural space. At the lumbar level, there are no posterior veins. All the epidural veins are valveless. That means if you sit a patient up for epidural, you will have more vessel punctures. So trying to do it in a lateral position is much better for the baby, and also you won't be hitting a vein. Epidural arteries are all in the lateral epidural space. So if the epidural is not in the midline, then you may puncture an artery. Anterior epidural space has lot of septate fats. So if the catheter goes in the anterior epidural space, the block will be patchy. So my take home thing from this slide is stick to the midline, use more and more ultrasound, and CSE should be the answer for all those things. I have never done an epidural I do quite a lot of labor anesthesia, almost 3 per day. I stopped 8 years doing any epidural. I only do CSE. I will come to it afterwards, why I do it. Never thread the catheter greater than 5 centimeters, because it will either go to the lateral place where you don't want it, or in the anterior space where it won't work. We'll come to where is the pain coming from during labor? Is pain bad in labor? And what are the analgesic options we have? The pain is 2 stages in labor. Stage 1 is all visceral pain. It is carried by sympathetic nervous system. It is very vague, and it is irritating sort of a pain, but it is not very sharp. Stage 2, all because of the distension of the lower pelvic structures, the cervix, the levator ani, they cause severe somatic pain like cutting a toe or an amputation like pain. So it is very severe, very sharp, and these are carried by the pudendal nerves. So sacral analgesia is the most important component of labor analgesia, not the visceral pain of the stage 1. We will cover stage 2 by both visceral, because there will be uterine contraction followed by somatic pain in terms of the lower pelvic structure distension. So the summary of pain origin is: first stage is visceral, very dull, very vague. Second stage has a somatic plus visceral, which is very sharp and very localized. Is pain bad in labor? It is. If you say respiration, there will be hyperventilation. It causes shifting of the oxygen dissociation curve and causes fetal acidemia. Cardiovascular systems, as we all know, that it can cause a lot of unwanted perturbations. Postpartum depression has been associated with uncontrolled pain during labor. Treating pain can have beneficial effects on uteroplacental perfusion. So I will stress this very important fact that adrenaline, which is released in everyone's body because of pain, is a stress hormone. It is a tocolytic. So more and more adrenaline produced causes more uterine relaxation. So the labor gets prolonged and the contractions never get effective contractions. So more and more pain, it slows the labor down and it causes less powerful contractions. So in this chart, you will see that everything, all the pain and the stress by release of the stress hormones ultimately lead to fetal metabolic acidosis. This is the most important cause, is the hyperventilation cycle. So it is a two-way sword. Between the contractions, there is a increase in the respiratory rate and there will be decreased maternal PaO2. During the contractions, there will be more shifting of the oxygen dissociation curve and there will be decreased oxygen delivery. So it's a two-way sword to harm the baby, that the baby won't be happy within the mother's womb. How can you modify the labor pain? You can do psychological things like antenatal classes. These are the non-pharmacological pain relief. I won't go into details into that. There are physical causes of pain that changes the pain perception of the patient, is occipito-posterior position. And if a mother who has a history of severe dysmenorrhea before becoming pregnant, they have severe labor pain. Physiological causes, the role of progesterone. We all know progesterone is a anti-nociceptive hormone that God has created as a thing that should be released during any painful labor period. And there are pharmacological modifications. So modalities of pain relief are non-pharmacological, pharmacological, and we should inform the public that whatever we are designing, it's all safe for mother and baby. It won't interfere with your progress of labor, and there will be flexibility that as the labor progresses, we know that you will need more pain relief. We can adjust with some recent generation epidural pumps and stuff. There is no increase in instrumental or cesarean section that will be caused by the anesthetist. I will come to it, the evidence base. So these are the non-pharmacological. I've just underlined the water bath because we practice in UK quite a lot of water bath. We just put a tub, and these are the Cochrane databases of all the non-pharmacological, everything has a database. So it works if you combine it with a lot of other. So it's a multimodal pain therapy. So coming to the water birth, a lot of mothers actually want it. It is a very relaxing in a hot water birth, and the babies are delivered submerged because they are under the water. They will never take a breath. So after the baby is delivered, then we cut the cord and then we lift the baby up. When the baby is up, we can never take it back to the water. So that is a very good thing that a lot of mothers want it, and they deliver it successfully. Low risk pregnancies. In the pharmacological side, we use quite a lot of Entonox. It's a 50-50 nitrous oxide oxygen. And in some countries, not in our country, 0.8% sevoflurane with oxygen is also used. In the parenteral, there is a poor women's epidural, I should say. It's a remifentanil infusion, PCA remifentanil, sorry. And pethidine, these are all outdated. Still, people use it. And paracetamol is actually even better than pethidine. In the regional updates, we are trying to move from epidural to combined spinal epidurals and dural puncture epidurals. And there is this walking epidural, lot of people practice. I think it's more of a hype. I don't know whether it works. I have tried it. It works, but it is only for 20 minutes, 30 minutes, and they all come back to the bed. Entonox, I will skip this one. So as I told, paracetamol IV is much better than pethidine, and the duration lasts for 2 hours. The opioid boluses like pethidine, it should be outdated. Opioid does in labor analgesia doesn't have any analgesic effect. It is only because of sedation. People still use it. We also use it in UK. This is the newer edition, IV PCA remifentanil. It's not equivalent to epidural, but it works. But the main problem is the patient becomes apneic very quickly. So we have to be supported with a lot of 1:1 care. In the neuraxial, that is the gold standard. Initiation, we have conventional epidural, CSEs and DP, and the maintenance, there are lot of newer advances moving away from manual bolus and continuous infusion. In the preparation, the most important thing is you have to have ensured that that is a normal CTG for 20 minutes. The reason is adrenaline, as I told you, it relaxes the uterus. It's a tocolytic. If you give a pain relief in form of neuraxial analgesia, then the adrenaline level plummets to so low level, the uterus goes into severe contraction. It's called tachysystole. When there is a tachysystole, the spiral arterioles are completely compressed and there is a severe dearth of blood flow to the baby. So there will be category 1 section if you don't have a normal CTG for 20 minutes. Only do any neuraxial blockade if the CTG is normal for 20 minutes. Intravenous infusion, it's very, very important to prevent any hypertension. In the epidural insertion equipment update, the aseptic procedures, mask is a most important thing. So there is a 2017, it's very strange still at this time, like we are reaching 2020, when a Canadian consultant anesthetist did back-to-back neuraxial analgesia, anesthesia without wearing a mask, and he was hell-bent that I'm consultant, I don't need to wear mask. And both the patients had a severe meningitis, and the PCR of all the bacteria were exactly matching with the nasal and the buccal flora of that anesthetist. So it is very, very important. And chlorhexidine, never use any 2%. You have to use 0.5% because 2% is considered neurotoxic. And remove all gallipot. You have to spray or do cleaning of the skin and throw away the. You will know the Australian. There is a picture where a mother had a chlorhexidine guided epidural. Everything went into epidural, and she never got her legs back after 15 years. We in the European countries, we have moved into the NR fit. It's a neuraxial needles. It has a different hole. It's a non-lure. You cannot fit any normal syringes with that. So it is a yellow system, NR-FIT system. It's for more safety. This is the newer advances in the last 1 year. The last one is a single hole or the multi-hole catheter. It is no use using a single hole catheter. It doesn't do any good. Multi-hole catheter, I will come to it in a later slide. That is the must for if you want to do a proper neuraxial anesthesia. So is epidural a gold standard? I will probably go against it. It's not a gold standard. So if you see that the sacral anesthesia, which I was talking, it takes around 25 to 30 minutes to get it. The failure rate is quite high, and the failure rate for conversion to CS is also 5 times higher. You probably cannot do walking epidural because of more motor block. If there are fixed cardiac output disease like aortic stenosis, you can use only a CSE with a fentanyl. Don't use any local anesthetic. You cannot do it with an epidural. It doesn't work. And the midline identification is never guaranteed with an epidural. So moving on to that, you can use aids to use more sort of have a successful epidural, like using a technology things, CompuFlow pressure waveform. This gives you a cardiac pulsation waveform after you connect it with the monitor. The balloons, the Macintosh balloon were very popular when we were postgraduates in India. We saw it, we didn't use it. And there are pre-procedure ultrasound. I always tell all my trainees to do almost every patient ultrasound. After that, you do it. And the newer advances of techniques, CSE and DPE, because we have a CSF as an endpoint, we know that this is the midline. So this is the combined spinal epidural. So combined spinal epidural compared to epidural, sacral anesthesia is achieved in 2 minutes. The failure rate is the least in all evidence-based medicine, all journal articles. The failure rate for top-up is also the lowest. Walking epidural can be done because in the first stage, you don't need any local anesthetic, only use a fentanyl in the spinal. So patient can walk around. Fixed cardiac output disease, again, you can use only fentanyl opioid-based, no local anesthetic. And the midline identification is guaranteed because you have a CSF. So it is a little bit of a fast and furious because you get an analgesia in 2 minutes, adrenaline level goes down so quickly. So it can cause fetal bradycardia. That is the only disadvantage. But there are so many advantages that it can produce effective sacral analgesia. The funniest part is a CST can actually make a dilatation of the cervix much, much faster. So the labor will be shortened. So the common misconception that neuraxial analgesia prolongs the labor, it is a myth because you are taking out the adrenaline, which was a tocolytic. So you are making the uterine contraction, which leads to cervical dilatation, much more faster. You should use it more in obese patient or high BMI patient. And if a patient asks in OP position, if there is a malpositions like OP and difficult back, and if there is unusually intense pain. There is a risk of a damage to the conus medullaris. It is a very, very high risk if you don't do ultrasound. Remember that the pregnant mothers are having lumbar lordosis. So whatever you test about the Tuffius line, the highest point of the iliac crest to get your L3-4 is never right. And I can prove with ultrasound that every of my PGTs, they are always wrong with the level. So they do it at L2-3. So because of the lumbar lordosis, the line of the Tuffius line goes up. So you can damage the conus medullaris. Conus medullaris, as you all know, is the end point of the spinal cord. So the CAC, the side effects is related to the intrathecal drugs like the pruritus. It is only because of the opioids. I don't use any opioids. I only use, if I use just for labor analgesia, I only use some very low dose bupivacaine. But if you use fentanyl, if you have to use only 10 to 15 microgram, that doesn't cause that much of pruritus. Hypotension is a theoretical risk. CNS infection, conus damage, these are all theoretical risks. But if you do with ultrasound, these risks are much, much lesser. Does it cause motor block? Yes, it can cause motor block for the first 30 minutes. After that, it doesn't. If there is a motor block, then you don't start the epidural infusion. And the bradycardia is the most important thing. I will come to it in a very short while. The fetal bradycardia. So fetal bradycardia after anything, any labor analgesia that you do, it can happen from 3 to 20%. Epidural rate is 8%, CSE rate is 20%. So it can be caused by hypotension just because of the neuraxial. It can be caused by the decreased adrenaline, which I stressed in before. And neuraxial opioid, fentanyl, causes bradycardia, as we all know. And because the adrenaline level is low and you have a severe tachysystole, if you use concurrent syntocinon or oxytocin, then there will be more contractions. So I always stop the syntocinon 5 minutes before I do a CSE. If you do it a lateral CSE, it is much better. This is part of the intrauterine resuscitation. Babies are always happy in lateral position. I avoid opioids if it is necessary that the CTG is a bit dodgy. You can avoid opioids, but it's cardiac patients. You have to use only opioids in the start, in the beginning. Always switch off the oxytocin, and IV fluids and vasopressors should be ready. If there is a fetal bradycardia, you don't have to rush to theater with a category 1 section. You can do this management, which is a mnemonic of a spoiled. Switch off the syntocinon, turn the patient to the left side, give fluids, and you can use terbutaline as the tocolytic. So there is always a fight in the whole world still. The Europeans and the Americans still feel that the CSE is better than epidural. I have never done it for 8 years, any epidural. I only do CSE for labor anesthesia. DPE is the American invention. They always do something different. They want to do something innovative. So this is a dura is punctured. You get the midline. CSF is there. Don't give any medication. So there will be now a hole which causes a transarachnoid translocation of your local anesthetic. You give a normal epidural that will hasten the onset. The sacral coverage is better and there is a better analgesic quality. But remember, never do the CSE with the spinal needle less than 25 gauge. So if a 27 gauge, if you use, the hole is so small, it seals itself. The DPE doesn't work. So if you have to use a CSE and a DPE, always use a 25 gauge at least to make the hole be patent. The onset of CSE is around 2 to 3 minutes. DPE is 7 to 10 minutes. Epidural is around 15 to 25 minutes. So as you see that the red ones are the most painful, as the labor progresses, it's all the sacral things. And all throughout, always the lower part of the body is having the maximum amount of pain. So the sacral analgesia is the most important component of labor pain. Epidural test dose, everyone has tried everything, like local anesthetic, adrenaline, chlorprocaine. Chlorprocaine is one of the ultra short acting, quickest acting local anesthetic. We use it quite a lot, but everyone has loads and loads of disadvantage. So I never use it, and it shouldn't be used. In the modern literature, it says that it is not applicable nowadays. So using a multi-orifice catheter, the aspiration is falls in blood aspiration is falls in 2.3% in the single orifice catheter. If the multi-orifice, it's only 0.6%. So my mixture is, this is one of the, every hospital has their different mixture. My this is the best epidural mixture. This is epidural mixture. So you can use this one. I think Shumana is going to share the slides. You can use it. So administration of this mixture is done at a 7 mils, 5 minutes wait, 7 mils, 5 minutes wait, and rest 6 mils. It works always better. And even if there is an intrathecal transfer, you will get the results within that 10, 12 minutes. Or if there is a vascular, you will never have a local anesthetic toxicity, but you will have some bradies. So maintenance, as a sum up, you have to use multi-orifice catheters, and there are lateral ports. Why it is so? If you use an infusion in maintenance, it only engages, mostly epidural catheters have 3 holes. Infusion only engages your proximal port. So it causes a concentration effect. So it all rests within the cauda equina area and gives you more and more motor block. But if you use a bolus, even a manual bolus, it engages all ports. If we use a pump, the pressure, the speed generated is around 280 mils per hour in the modern pumps. So it engages all the ports, and the height of the local anesthetic spread is very, very good, and it only affects mostly the sensory fibers. So there is more cephaloid spread of the local anesthetic by using multi-orifice catheter with a bolus by a machine or even a hand bolus. So these are the types of maintenance. I will just stick to the last line. The patient control epidural anesthesia and a programmed intermittent epidural bolus by an automated system. It gives you the widest spread, the best sensory block, and it is a sort of an artificial intelligence. It actually calculates how much the mother has used in the last hour. So the next hour, they will then modify the infusion. It is a Singapore-based model. We use it. It is a fantastic model. You can use those sort of advanced pumps. These are the newer pumps. The breakthrough pain during labor, you have achieved a very good pain relief, and in the middle of the labor, the patient complains of severe pain. So always consider whether it's a full bladder. The bladder, if it is not emptied, it halts the progression and the spread of your local anesthetic. The higher risk things are the uterine rupture. If there is occipito-posterior, always give another extra bolus to maintain a more sacral anesthesia. It can migrate to the subdural spaces. And this is another new thing, is the chorioamnionitis. Probably those mothers who have more and more pain during labor, probably they have a subclinical chorioamnionitis. Talk to obstetricians about it and never thread it beyond 5 centimeters. In the monitoring, you will do the normal monitoring, Bromide score, block height, everything. I just highlighted in the blue is the temperature monitoring is the most important thing in modern day neuraxial labor analgesia. I will come to it in later slide. The abnormal finding during the assessment, during the whole block thing is sometimes inadequate analgesia, dense motor block, patchy motor block. I won't go into the details. But the breakthrough pain, remember full bladder, uterine rupture, abruption, and OP or any transverse lie or malpositions. So preventing, it's again, if you have to recite, always do a CSE, never do another epidural. It's not going, the evidence says it doesn't work. Never use air because because of the air pockets, it can cause patchy analgesia. So always use saline. And again, the same thing. The new recent advances, we don't have it. Recent is the wire reinforced flexi catheter. They are fantastic. I think Becton Dickinson markets it. They are the best to prevent any vessel penetration, and it gives the better analgesia according to their literature. So till now, the epidural summary, there are good things that it makes contractions effective. The fetus is healthier. The bad thing is accidental dural puncture, local anesthetic toxicity, patchy blocks, subdural blocks. The ugly thing is, we all know total spinal, and the GA conversion for CS, your epidural top-up didn't work. So the last part of the lecture is the newer insights into the myths and controversies. Does it cause operative and instrumental delivery more? It is definitely no for cesarean section, but maybe for instrumental. But never use more than 0.1% of anything, bupivacaine or ropivacaine. In that case, instrumental also doesn't change. So if you use 0.2 and 0.25%, yes, instrumental rates will increase. Early versus late. So if a mother requested a 2 centimeters dilatation, would you do it? In UK, we never did it till 2018. But after the ACOG recommendation, we have started to move. But remember, if an epidural runs for greater than 5 hours, primip can have a labor for 5 hours. Epidural fever is a known entity. Temperature, this is the most important thing in the recent times, like 2 years, it has become very popular. So epidural related maternal fever is around 11 to 33%. Why it happens, we don't know. Whenever it happens, you subject all the neonates into blood tests, sepsis, antibiotics, and special care units. So this is a very, very important point, that how long greater than 5 hours epidural can cause mitochondrial dysfunction by the local anesthetic. It can increase, these are the newer substances which has been described, alarmins, inflammasomes, and lot of cytokines. Probably these all mothers who had intense pain at 2 centimeters dilatation, they have a condition called subclinical chorioamnionitis. That's the reason they asked for the epidural, and we provided the epidural. And now the epidural has lasted 5 hours. It causes these. It is all local anesthetic related mitochondrial dysfunction. It can cause neonatal sepsis and encephalopathy, but we don't know. It's still under lot of research. Backache and epidural. Epidural analgesia doesn't cause any backache. Assure your patients that your backache is because of your progesterone-related ligamentous relaxation, not because of epidural. TOLAC, trial of labor after a cesarean, or in UK we call it VBAC, vaginal birth after cesarean, and epidural. The SOAP and ACOG, they consider early epidural. Epidural and breastfeeding, I will just tell you to go into this very funny website, sarahbuckley.com, and she tells that a mother having too much of fentanyl infusion during labor can go into the baby, and the baby has opioid related muscle hypotonia, and whenever the nipple, mother's nipple, come to their cheek, they don't clutch the nipple. So it is called an epidural gape. It is all misnomer. All Cochrane database and everything has refuted this claim that there is no association with breastfeeding and epidural, but still that you will see in MomsNet, there is a website for the moms. They search for it quite a lot. Withholding top-ups in second stage to help pushing, it 0.1%. You shouldn't stop anything at all. You should give more pain relief during the second stage because mothers have more pain during the last period of the delivery time. Early versus delayed pushing. So whenever you have epidural, you have to encourage the obstetricians that never, even if the mother is fully dilated, you have to tell them to do passive descent. This is from the People study, pushing early or pushing late after epidural. It has proved beyond doubt that after full dilatation, let the baby descend by normal passive descent. So you should wait 1 hour before they start actually actively delivering. Optimal PCEA, we do PCEA. So the mothers press a button is same like the PCA morphine that you use after surgery. So the current consensus in the blue, I have written high volume and long lockout, 12 mils every 25 minutes is considered one of the best in the most evidence-based journals. Remember, some mothers won't get any some pain relief because of this single nucleotide polymorphism thing. Some opioids doesn't work in those sort of, it is pharmacogenetics has come into a very new research things that why some mothers don't get proper pain relief. So you can use a normal local anesthetic only without an opioid. So this is the last bit. It is for the postgraduate students. So if you have to give a top-up, a patient is having a little bit of pain in the perineal region, later stages of labor, which one would you give? 0.5% 4 mils, 0.2% 10 mils, or 0.1% 20 mils? It's the same total amount is 20 milligram. So the answer is the 20 mils gives you the best. Okay, so I will just quickly add this, the last two lines. You remember there is a MLAV and the MLAD. These are also very good things to know for the postgraduate students, that the minimum local anesthetic volume and minimum local anesthetic dose. So bupivacaine 0.125%, it produces analgesia equivalent to that provided by 0.2% with a 50% increase in volume and 25% reduction in dose. What happens? You have least amount of motor block and the mother can push the baby out. So that is very, very important. Use 0.125 with a higher volume. Don't use stronger stuff. So conclusion, it is extensive motor blockade can impair expulsive efforts. So use patient controlled epidural anesthesia with an intermittent bolus, never continuous epidural infusion. CIE is not recommended now. CAC is my choice for initiation. Remember, if there is a bradycardia, you as an anesthetist have to be there and also help with the resuscitation. It is called intrauterine resuscitation, spoiled. Standard epidural do not need any test dose. Always use a multi-orifice catheter. if there is a prolonged labor with epidural, 2 more minutes. The caution is fever. Adjuvants like clonidine, and these are unlicensed drug, so never use it, and never use adrenaline as an adjuvant. It causes severe motor block. Thank you. And he's still thinking, should I recommend or offer labor analgesia? Thank you very much.
Thank you very much, Kaushik Das Gupta sir. Your presentation really beneficial for us, especially for young anesthesiologists of the this region, East Zone. So very nice presentation, sir.
Thank you.
So,
thank you.
Sir, one question from, are you trying to suggest that labor analgesia with central neuraxial block should not be done in center without ultrasound?
No, it is, see, most centers don't have. In my hospital, I would say there are 16 anesthetists. And it is very shameful to say that only I am trained. So we are trying to, in the whole world, I teach in ultrasound. I have come to Calcutta also to teach ultrasound. This is the new, because this is the update in labor analgesia. So everyone, you should learn ultrasound. It's a very simple procedure, and it is one of the best to prevent any patient harm. No, it should be done. It should be done. We have all done it for so many years.
Okay, sir. And next question is DPE and sole epidural for the labor analgesia be performed in the same space or DPE in the lower space?
If you go into the 2013, the NAP4, the Royal College survey, the Royal College survey said that in the same space, it probably caused more nerve damage. But at that time, ultrasound was not in vogue. It was all talking about chorda equina and conus medullaris. So if you have an ultrasound, you can go in the same space. But there are studies which says that different space is probably safer. I only do it in the same space with a combined spinal epidural kit. And I've never had any nerve damage. I never had any problems. Yes, fetal bradycardia has happened, but neural damage, nerve damage has never happened. And I'm seriously telling you that I do almost around 15 per week, only CSEs for labor analgesia, and never ever had any nerve damage.
Sir, what are the cause of the fetal bradycardia? Because a local anesthesia can cause T1 to T4 accelerator, cardiac accelerator fiber blockage. But
with the labor analgesia, the block height never goes up to that side. You only need T10 to S3. That is your labor analgesia domain. Now, the most important thing is during pain, the adrenaline is very high. Catecholamines are very high. All adrenalines are tocolytic. They are uterine relaxant. So if you are taking the pain out by doing a pain relief, then the adrenaline level goes down so fast that the uterus goes into spasm. So as you know, the uterine muscles, they transmit the spiral arteries to supply food and nutrition and oxygen to the baby. So now you are compressing the spiral arterioles so much, then the baby will suffer. That's the whole point. It's called the uterine tachysystole. So that is the cause of fetal bradycardia. That is the commonest cause of fetal bradycardia.
Thank you. Thank you very much, sir. Thank you very much, respected Kaushik Das Gupta, for your nice presentation. Thank you, sir.
Thank you. I can log out, no? Yeah.
Yes.
Yeah. Thank you very much.
Okay. No, sir. This is the time of vote of thanks. So on the behalf of Indian Society of Anesthesiologists, East Zone, I thank you, all the speakers, all the delegates who are listening very cautiously, and a special thanks to our Dr. Kaushik Dasgupta, Dr. Sekat Sen Gupta, Dr. Asif Ahmad, Dr. Nishant Sahai, Dr. Sandeep, and Dr. Asif Ahmad. So you all are presented the topic very nicely.
Dr.
And a special
Swagata.
thank to
Dr. Swagata.
Swagata Tripathi. She is from AIMS Bhubaneswar. So thank you very much to all of speaker, and thank you very much to all the delegate who are listening, and thank you very much to SCP Forum, and not last and the least, Francis Kirby. Very thankful to you arranging all the things, and our speaker is high quality. So thank you very much, Francis Kirby and SCP Forum. Thank you. And I request to Francis Kirby to kindly arrange this type of webinar for ISA East Zone in near future also. That's the thank you very much to all of you. Good night. Good night.
Good night.
So some words from the Princess Kabi side.
So Rishi, you are not audible.
Am I audible now?
Yes.
Okay. Yeah.
Okay. So a big thank you to Dr. Manoj for moderating the session for today's evening. It was very nice, Dr. Manoj, and we are so much grateful to you for moderating this session and accepting the fact that certainly, yes, I am also thankful to ISA East Zone to provide us this big platform wherein we also get this opportunity to come and share our insights with all of you. Thank you so much. And I would like to say a big thank you to all the speakers for the day as well. Dr. Saket, it is always our pleasure to listen to you, and it was a great learning session as far as your presentation was concerned. A big thank you, sir. And along with Dr. Saket, I think it was honor to listen to Dr. Kaushik as well. It was a great honor for all of us. Thank you, Dr. Kaushik. Along with Dr. Kaushik, I would also like to thank Dr. Sandeep and Dr. Nishant, Dr. Swagata, Dr. Asif for sharing their experiences and insights with all of us. And I also express my gratitude to all the participants who have joined across the zones in one platform, and who are always there in this forum. Thank you so much. And a big thank you to our HCP forum team who have done a great job, Vijita and Jayati. Thank you so much for all the technical support that you have extended to us. Good night to all, and it was a great evening. Thank you so much, sir.
Thank you. Thank you. Good night, sir.
Thank you.
Good night to all of you, all the speaker and all the delegates.
Thank you.
Thank you.
Thank you.